thank you for coming to this wonderful, great program.
Sagantaan kun Konfiransii Qorannoo Biiroon Fayyaa Oromiyaa Marsaa 2ffaaf qopheesseedha. Keessummaa keenya kabajaa Ministeera Fayyaa Dr. Liyaa Taaddasaa, hoogganaa Biiroo Fayyaa Oromiyaa Dr. Mangistuu Baqqala, aanga'oonni mootummaa olaanoo Qo'annoo warreen gaggeessitan hayyoota yuunivarsiitiiwwan irraa pirezidaantoonni keessummaa keenya asitti argamtan, abbootii gadaa, haadholii siinqee, baga nagaan dhuftan anaa dhufu.
The issue of health is a serious issue that has to be supported and backed by scientific research and scientific findings. So the Oromia Regional Health Bureau has been doing great in this regard. And now I urge all of you to thank the Oromia Regional State Health Bureau. Amilenu Kennafi, Biiroo Fayyaa Oromiyaa.
Fayyaan murteessaadha. Guddinni biyya tokko kan dhugoomu hawaasa fayyaa buleessa yoo qabaateedha. Biiroon Fayyaa Oromiyaa immoo hawaasa fayyaa buleessa horachuuf wanti tokkoyyuu osoo hin daangessin hojii cimaa hojjechaa jira. Kanaaf keessaa immoo qorannoo irratti hundaa'ee ragaawwan barbaachisuun murtee barbaachisu tajaajila fooyya'aa kennuuf qorannoo akka kanaa kana qopheesse. Qo'annoon konferansiin kun jechuudha marsaa 2ffaaf qophaa'e. Kanaaf Biiroo Fayyaa Oromiyaa guddaa galateeffanna.
Adding to this, to remind you that Oromia Health Bureau has awarded the presidential award for its outstanding performance. This is the result of great and committed professionals out there beside security challenges and other problems, and this is their achievement. Now I urge all of you to stand up and put your hands together for the Oromia Health Bureau and for those great professionals out there.
Biiroon Fayyaa Oromiyaa hojii inni hojjeteen raawwii bara 2015 jechuudha. Raawwii olaanaa galmeessisuun sadaffaa ba'uun presidential award yookaan badhaasa prezidaantii argateera. Kanaaf ol kaatanii otoo galateeffattan guddaa nutti tola. Ifa moolliin ol kaate yeroo tokko hundi keessanuu waan salphaan kan dhufe miti. Haalli nageenyaa otoo hin daangessin, gaarri otoo hin daangessin, aduun roobni otoo hin daangessin, ogeeyyiin fayyaa sadarkaa gadiitti jiran hanga ispeeshaalota jechuudha hojii isaan hojjetaniin qindoominaan kan dhufedha. Guddinni biyyaa akka tufuufis hojiin Biiroon Fayyaa hojjechaa jiru kun hojii laayyootti ilaalamuuti, dhimma fayyaati. Nu fayyaan waan taaneef asitti argamne.
Thank you all. Thank you. You may be
Galatoma,
seated. Thank you.
Galatoma.
Now, as you know, Oromo has a great and beautiful culture of starting any program, and Oromo has a culture of blessing things. And for the successful of this program and research conference, now we call upon the Bagadas to take the stage and start the program with blessings.
Oromoon aadaa boonsaa qaba. Waltajjii waloo akkasii yeroo jalqabu immoo eebbaan jalqaba. Wanti inni eebbaan jalqabe akka milkaa'uuf amana waan ta'eef. Kanaaf abbootiin gadaa gara waltajjiitti dhufanii eebbaan akka sagantaa keenya konferansii kana nuu saaqaniif gaafannaa abbootii gadaa gara waltajjiitti nuuf simadhaa.
Please join us to welcome Bagadas.
Wani nagata alafti nagataati wani nagata alafti nagataati waaqa lafa jidduutti wan nagata waaqa lafa jidduutti namni nagata waaqa lafa jidduutti namni nagata nageenyi ititee ollaa ganda nagaa godha nageenyi ititee ollaa ganda nagaa godha namni fayyaa qabu urmii isaa keessatti gammachuudha namni fayyaa qabu urmii isaa keessatti gammachuudha namni hunduu fayyaan dhabin namni hunduu fayyaan dhabin namni hunduu fayyaalessa haa ta'u Leen irraa haa qabu, dhukkuba qileen irraa haa qabu, beela misooman irraa haa qabu, diina waraanan irraa haa qabu. Waaqayyo dhalti namaa kamiyyuu lubbuu qabeeyyiin kamiyyuu waaqayyoon dhibin lubbuu qabeeyyii kamiyyuu waaqayyoon dhibin wanti hojjettan wanni karoorfattan milkii waaqaa lafaa bira haa jiraattu milkii waaqaa lafaa bira haa jiraattu wanti yaaddan marti isinii haa taatu wanti yaaddan marti dhala namaatii haa taatu horaa bulaa badhaadhaa deebana.
Naaf kalcha hayyee waaqumaa gurraacha garaa garbaa tokkicha maqaa dhibbaalee immoo garaa tajaajila biyya nagaa keessa nu jiraachifte lafa nagaa nu bulchitee maatiin nu geesse lafa nagaa nu oolchi biyyi keenya biyya nagaa haa ta'u innaan keenya nagaa haa ta'u guddaan keenya nagaa haa ta'u xinnaan haa guddatu guddaan oolee haa bulu wallaalaan haa beeku waaqixxaansee namni keenya yoo dhibamu sin harkadha jira namni nama keenya du'a jalaa baasu warra ogummaa qabdan kana ogummaa keessa waaqayyo dachaan isiniif haa dabalu warra ummata keessan baraartan rabbi isin haa godhu warra ummata keessan gargaartan rabbi isin haa godhu waaqayyo fayyaaf nagaa isiniif haa godhu nagaan biyya keenya irratti haa eegutu namni keenya oolaa jaalatu akka shittoo walitti haa urgaa'u akka dammaa walitti haa mi'aawu horaa bulaa gadaan qofaaf gabbina.
Karannaan keenya waaqa lafaa haa ta'u toltuun Oromoo haa ta'u korri kora milkii haa ta'u.
Abbootii gadaa simadhaa. Abbootiin gadaa bakkee isaanii qabatu nuuf simadha.
Egaan kabajamtoota daawwattoota keenyaa kan daawwachaa jirtan sagantaa qorannoo yookaan immoo riisarchii lammaffaa Biiroo Fayyaa Oromiyaati. Akkuma dura jennee dhimmi fayyaa dhimma jireenyaa fi dhimma lubbuu waan ta'eef qorannoon sirriitti deeggaramuu qaba. Akkasumas bifa saayinsawaa ta'een irratti hojjetamuu qaba. Kan immoo Biiroon Fayyaa Oromiyaa xiyyeeffannaan irratti hojjechaa tureera. Kanaaf badhaasa Presidential Awards sadarkaa sadaffaa bahuudhaan kan badhaafame. Dhimmi kun akkuma sila jennee dhimma akka naayyootti ilaalamuu miti. Rakkoolee jiran hundumaa dandamachuudha rooba ganna bona aduu osoo hin jedhin rakkoolee nageenyaa jiran hundumaa osoo hin sodaatin osoo duubatti hin deebiin lubbuu lammiilee miila hedduutti lakkaa'aman baraaraati kan jiranii. Kanaaf ammas ogeeyyii fayyaa ala jiran warreen as jiranis hooggantoota as jiranis baay'ee galateeffanna.
Dhimmi fayyaa baay'ee murteessaadha. Oromoon gaafa wal argu saanamaan gaafata. Kun nagaa gaafachuun isaa fayyaan isaanii akkamii waa'ee fayyaa duuba isaa kan gaafachaa jiru. Kanaaf Biiroon Fayyaa Oromiyaas hawaasa fayyaa buleessa horachuuf eenyuyyuu rakkoon fayyaa yoo isa mudate qofa osoo hin ta'in yeroo hundaa fayyaa isaatiif akka dhimmamu hojiilee garaagaraa hojjechaa jira. Hojiiwwan inni hojjechaa jiru keessaa akka fakkeenyaatti inshuraansii fayyaa kaasuu dandeenya. Qotiyyoof qanbarri gargar ba'uun hafeera. Haadholiin gudunfaa isaanii karoora malee hiikachuun hafeera. Tajaajila inshuraansii fayyaa hawaasaatiin hawaasni hedduun hamma hunda jechuu dandeenyutti tajaajila yaalaa bilisaa argachaa jira. Kun hojii xiqqaa miti. Hamilee nuuf kennaaf.
The Oromia Regional State Health Bureau has been undertaken the health insurance and other WHO and other programs. It is already implementing the program from WHO and from the Ethiopian Ministry of Health, and this is shows as the government has given great attention to the health, especially in the region and beyond that. We thank the Oromia Regional State Health Bureau. And now, join me to welcome Dr. Tasfai Kebabo, Deputy Bureau Head of the Oromia Regional State Health Bureau. Then he will deliver us his opening speech. Thank you. Please join us to welcome him.
Hoogganaa Itaana Biiroo Fayyaa Dr. Tasfai Kebabo gara waltajjiitti affeerraa nuuf simadha.
Abbootiin gadaa keenya nuuf galcha. Your Excellency Dr. Liyaa Taaddasee, Ministry of Health of Ethiopia. Your Excellency Dr. Mangistuu Baqqalee, Head Oromia Health Bureau. Your Excellencies Dr. Getachew Tolera, Deputy General Director of Ethiopian Public Health Institute. Dr. Garrammoo Hulluuqaa, President of Oromia State University. Innocent, the field hub of WHO, Dr. Ngozi Kennedy, health section from UNICEF, Professor Sunil Girma from Harvard, respected university president and academic researchers, all representatives from Zona Health Department as well as from the hospital, private sector, and the professional association. Honorable Abagada and Hadesike, ladies and gentlemen, it's my great pleasure to welcome you to Oromia Biiroo Second Annual Research Conference in Addis Ababa at this Skylight Hotel. Welcome, Baganagan Duftani, Anadufusni Jenna, Baganagan Duftan. This year conference theme is tackling health service delivery bottlenecks through evidence-informed decision-making, having with three sub-themes: quality data for service delivery, innovation, the technology for service improvement, health service delivery in emergency setting, as well as leadership of health service. The main objective of this conference is to map available evidence from elsewhere, from university, from health facility, as well as from other else. The other one solicit potential solution against them, identify innovative evidence and translate it to the healthcare delivery system, and bridge the evidence generation and the translation bodies together. Based on this, we call about 27 oral presentation and the 29 poster presentation, the 3 panel discussion. This event is believed to bring the various stakeholders from every corner of the region and beyond, including the ministry, representative from university, health sectors, as well as different health sectors which support the health, private sector, professional association, and the advocates. A resilient healthcare system that can meet the demand of modern society requires innovative and valuable evidence to solve the prevailing health challenges. Foster such innovation, strengthening evidence generation and translation activity, and establishing a conducive environment that strong collaboration is fundamental. For this, strong collaboration in the communication between university and the regional health bureau are useful for providing high quality, equitable health care, responding to public emergency as a system response. We have established different knowledge translation platforms like SAP, as well as a gala session at Biiroo, which is very important to bridge the gap between the university as well as the translating organization to present their finding, as well as to change to the dissemination, which was the base for the last year annual conference, which get the input from this conference for one, HOERT guideline preparation. The other one is identifying thematic area, and with the university data sharing with the other organization. The HOERT guide helps to frame our future research and the translation activity. This guide indicates how our distinguished partners as well as collaborator evidence generation management translated, especially for the university and other research institutes operating in the region. This is a golden time to configure and align research activity together to make this research investment effective and efficient. Unless otherwise, we will be subjected to massive wastage of a resource if there is no collaboration and communication between university and the other partners who are doing on the research. It will be subjected to a massive resource wastage. So the collaboration, the communication between research institution, university, and the implementing organization is crucial. As a region, we face with different public health emergency at this moment. Some of them are involving unpredictably, and the other is needing new empirical evidence. The other one is some requires other implementation parameters which have been not be addressed before these epidemics. We have been with cholera, we have been with malaria, but still there is a challenge, there is an outbreak. So we need an evidence, we need other innovative kind of innovation for the implementation and the response. While with this, I call upon our university, research institution, and the partner to collaborate closely with the Bureau to generate evidence, design innovative intervention, support the fight against the emergency. On the other hand, the modern system needs evidence-based decision. Globalization and the ever-changing environment increase the community desire for the quality of service and the development of diagnostic therapeutic technology, which fulfill the desire of our community, all are based on evidence generation as well as utilization of scientific evidence. The scientific conference aims to revitalize information utilization as a core function and tackle healthcare delivery system bottleneck through evidence-informed decision that aims the available evidence to address the challenges and reorient future research investment and intervention. At last, I want to express my acknowledgement and appreciation to all partners, the organizing committee, individuals working tirelessly to make this conference happen successful. Thank you for your time. I look forward to having productive deliberation from presentation and the panel discussion. Ogeeyyiin keenya godinarraa, hospitaalarraa, dhaabbilee adda addaadhaan yeroo adda addaa miidhamuudhaan tajaajila nuuf kennaa dhuftanii turtii gaarii iddoo kanatti akka argattan hawwii guddaa qabna. Iddoon kunis iddoo namatti tolu handhuura naannoo keenyaa waan ta'eef yeroo gaarii isinii hawwa. I invite Dr. Getachew Tolera, Deputy Director of Ethiopian Public Health Research Institution, to deliver his keynote speech. Thank you.
Konfiraansii kana keessattuu tajaajila qorannoo irratti bu'uureffatee tajaajila fayyaa fooyyessuudha. Guddaa galatooma.
Health Bureau, Oromia Health Bureau Deputy Heads, Honorable Abba Gada and Abba Senkes, distinguished delegation from Ministry of Health, Regional Health Bureaus, Regional Public Health Institutes, partner organization, academic institutes, and all invited guests. On behalf of myself and Ethiopian Public Health Institute, I am pleased to be invited to give keynote speech on the second annual research conference organized by Oromia Health Bureau, which has started today with the theme of tackling health service delivery bottlenecks through evidence-informed decision-making. Ethiopia has made major progress in improving maternal and child health in the past decades. However, the gains are not so equitable that there are disparities among regions and between urban and rural areas. Addressing the inequality gap, in addition to other emerging challenges such as epidemics and non-communicable diseases, remain as a priority task during the era of the Sustainable Development Goals. The Sustainable Development Goals agenda, a global agenda set out as inclusive and prioritize a core principle to leave no one behind. It is an international adopted set of universal principles, standards, and valuable to facilitate action for sustainable development across all countries. The SDG calls for universal action to end poverty, protect the planet, and ensure that all people enjoy peace and prosperity by 2030. The SDG targets are built on the successes of MDGs, extending to cover new areas of development as well as all countries. The SDG targets are interconnected, and success against them require a holistic approach across the full agenda of 17 goals and 169 ambitious targets. Ethiopia's target for 2030 is set to reach at maternal mortality rate to be 70 or less per 100,000 live births, proportion of deliveries attained by skilled health personnel to be 100%. Under 5 mortality rate to be 25 per 1,000 live births, and neonatal mortality rate to be 11 per 1,000 live births. In addition, primary health care coverage to be 100%. Immunization coverage for children under 5 years to be 100%. The health care workers density to be 2.3 per 1,000 population, and 100% for proportion of health facilities that have core set of relevant established medicine and available. To reach to these targets, evidence should be generated on implementation status of policies, strategies, and drivers and challenges that help to government to show its performance, the strengths and weakness, and the gaps. All the objectives need quality evidence to address the health needs of the Ethiopian population. Quality health data largely generated by the routine health facility reporting system, triangulated with data from periodic surveillance and survey. Allow government to develop a responsive and more resilient health system. Quality health system data are key to establish effective and continuous inequality monitoring system for tracking performance towards the national and international target and health equity at all levels of the health system. To enhance informed decision making and innovation, we aimed at improving evidence generation and use from numerous sources, including census, civil registration, and vital statistics, as well as survey, surveillance, routine information system, researches, and monitoring and evaluation systems. It's also focused on continuous improving the availability and quality of data, building capacity in data use core competencies, bringing the gap between data use and data producers, strengthening organizational data demand and use platform, documentation and communication of data demand and use success, data access and sharing security, and data warehousing. The challenge related to evidence use are many. First, they may not be related to the policy gaps and challenges. Second, the evidence may not be published, or the published not accessible. Program leaders may not know their availability, and there are at times disconnect between researchers and program leaders. To this effect, the ministry has established research and policy analysis unit closely working with EPHI and other research organizations to use the available data from different resources and make it accessible to researchers and answer priority research questions. So I want to extend my gratitude and thanks to Her Excellency Dr. Liat Taddese for establishing these units in the ministry. It's also highly believed that such type of event should facilitate ample opportunity for conducting, collaborating researchers among policymakers, academic and research institutions, and gives a chance for further discussing the roadmap of the health system research. Furthermore, it helps to produce strong evidence which helps the health sector to revise the strategies and program to achieve the national and international goals. I assure that EPHI will continue to play a collaboration role to the different actors who are working in the area of evidence to policy. I would like to take this opportunity to congratulate Oromia Health Bureau for organizing this conference under the theme Tackling Health Service Delivery Bottlenecks Through Evidence-Informed Decision Making. I wish you a very pleasant stay and productive and successful conference. Thank you so much.
We thank Dr. for this wonderful keynote speech, and from the speech we have understood that as the Oromia Health Bureau has been doing much more in improving lives and saving lives through evidence-based projects. And thank you, sir, and also we thank Oromia Regional State Health Bureau.
Du'aatii daa'immanii fi haadholii xiqqeessuu haadholiin dhaabbilee fayyaa keessatti akka dahaniif gochuu keessatti hojii guddaatu hojjetamaa jira. Kanaanis du'aatiin haadholiif daa'immanii xiqqaachaa jira. Naannoo Oromiyaa gandi ekstenshinii fayyaa hin qabne hin jiru. Rakkoon tokkoyyuu osoo hin daangessin hojjettoonni ekstenshinii fayyaa dabalatee abbootii warraa haadholii warraaf barnoota fayyaa dabalatee haadholiin buufata fayyaatti dhaabbilee fayyaatti akka da'an hordofii da'umsa duraa yeroo da'umsaa fi akkasumas da'umsa boodaa akka godhaniif hojii guddaatu hojjetamaa jira. Kanaaf egaa du'aatii haadholiif daa'immanii xiqqeessuun kan danda'ame kun hojii jajjabeeffamuu kana caalaa kan cimeetti fufuu qabudha.
Now join me to welcome our next speaker. Our next speaker is Oromia State University President Dr. Qo'annoo Marsaa. Please join me to welcome Dr. Qo'annoo Marsaa so that he can deliver his message.
President University Oromiyaa Dr. Qo'annoo Marsaa gara waltajjii taffeerraa nu simadha.
Thank you, sir.
Abbootiin gadaa akkam jirtu? Nagaa keessanii baga nagaan dhuftanii nuuf bulchitu. Afaan kun afaan qorannoo ta'ee fi kanaan haasofna. Baay'ee isin kabajna, baay'ee isin jaallanna, of bultii guddaa nuuf gootu jennee amanna. Her Excellency Dr. Liyaa Taaddasee, Minister for Ministry of Health, His Excellency Dr. Mangistuu Baqqalee, Head of Oromiyaa Health Bureau, dear Oromiyaa Health Bureau deputies, dear Professor Mirgisa Kaba, whom I respect and who was my advisor and is my advisor still, dear Professor Seleshi Garuma, Senior Health Profession, dear Abba Gadas, dear University Presidents, professionals, all participants. It's my great honor to have this short keynote speech in front of you. When I was informed to deliver keynote speech, I was thinking what to speak on this very important research conference. I thought in terms of two things. One, in terms of my current position as Oromia State University President. Oromia State University is doing on improving service delivery. Secondly, from my profession, I'm anthropologist, and I do have some little readings from medical anthropology. So I thought to speak or focus on three very important issues that maybe initiate the conference to deal and to debate. Of course, any research conference may create environment for debates, discussion, and idea. There is no one way or one solution for every problem. So the three issues that I speak very shortly are public service delivery, secondly, health service delivery, and third, informed decision making that are highly related with the thematic or theme of this conference. Public service delivery has a long history on the world. The traditional approach to public administration assumed that providing public service is to be the sole responsibility of the state. This was the traditional assumption. The state was the only responsible to deliver public service. But gradually, it brought failure, particularly in developing countries, because governments or states in developing countries do have different problems, like the governance capacities, the budget issue, the resource, professional issue. So they realized that with this limited capacity, state by itself or state only cannot provide public service delivery. Therefore, in the public administration professionals, in some period, there was a shift, the movement from traditional public administration to the public management approach. Shortly, we call new public management movement. This movement has brought paradigm shift to include public and private sectors, to connect the public sector as well as private sectors. Because during this time, this movement was begun in early 1980s. So during this time, private sectors were better than government sectors. So professionals thought that if we connect, collaborate state and private sector, we can tackle the problem of public service delivery. But this itself is not suffice. The third development came to focus on improving quality and expanding public service. So multiple actors should involve, not only private sector as well as state, but also other actors who can participate or should involve in public service delivery. This came to the issue of with a new concept we call governance. Rather than administration, rather than public administration, the concept of governance came. So the role of government is to govern the activities, but we do have multiple actors in order to improve public service delivery. So responsive government model is very important. Government should govern the activities, but many actors can involve, like civil society and the private sectors and others. It is here the concept of public service delivery should be understood from two perspectives, from supply side perspective as well as from demand side perspective. The supply side public service delivery refers to the production and delivery of public service through the involvement of multiple governance actors that include public agencies, private enterprises, NGOs, CBOs, and the communities at large. So it's expected to produce service as well as deliver service. All these are the actors. Thus, strategic design to improve the supply side public service delivery needs to focus on increasing the capacity and the incentive of public agencies and other services providers to participate in different ways so that they can best fulfill their functions. The demand side, the other one is the demand side of public service delivery, refers to the community members and their organizational capacity, the citizens. The citizens should put pressure on the actors in order to get quality service, in order to get quantity service, in order to get access. So the demand side refers to community members and their organizational capacity to aggregate and articulate demand toward the service providers with the objective of influencing the quality, you see. They are not passive. They should be active. So they have to demand the quality of the service, the quantity and the time of service provided, as well as to claim accountability. So there is the issue of accountability. Therefore, these are very important developments. But one very important thing is needed here. We have to have active citizens, aware citizens, responsible citizens who can democratically put pressure, and not only putting pressure, but who can engage in public service delivery. The second concept that I simply rush on, because it's not fair to speak about health before health professionals, but health service delivery from maybe sustainable development goal SGD reaffirm a goal commitment to achieve universal health coverage by 2030. This is common knowledge. Everybody knows this one. This means that all people and the communities everywhere in the world should have access to the high quality health service they need. Promotive, preventive, curative, rehabilitative, without facing financial hardship. I'm not here to tell you about this, but I want to challenge these participants of this conference. Can Ethiopia as well as Oromia achieve this universal declaration? And how? We have to discuss on these issues. The current WHO leaders do have confidence that the current WHO leaders believe that universal health coverage is not a dream for the future. It is already a reality in many countries. However, without quality health service, it can remain an empty promise. So they do have confidence that the issue of access is not a dream that we can achieve on globally. But my question still is, what about Ethiopian in general and Oromia in particular? Access, coverage versus quality. I hope this conference discuss these issues and come with innovative idea. The third concept that I want to speak is evidence-informed decision making. Decision making is everywhere. Everybody decides daily on so many things. And decisions may be wrong or right. But in terms of policy, in terms of health practice, the issue of evidence and informed-based decision is very important. Otherwise, leaders decide, professionals decide, family decide, individual decide. It's not the issue of decision, but whether the decision is based on the right information or not. So, especially in health issue, I know informed decision making is very important. What evidence informed decision making? Why we bother about information or informed decision making? Different studies show that the following issues are worrying. Actually, this data, this information is a little bit old, but I want to bring your attention to this. Billions of dollars are spent annually on health-related research. This is global truth. It takes approximately 15 years to get research into recommended policy. This is about early 2000s. I don't know the current status, but look, once research has been done, it takes on average on the global 15 years to be converted into policy. So policy, what does this mean? Policies are, we do have many policies, but they are not linked with the information, with the research, that means. 40% implementation in practice, 30 to 50% of people received recommended care, 30 to 40% parents do not get treatment of proven effectiveness, 20 to 30% of patients received acute care that was not needed. This data may be outdated, but forget about the numbers. But these are why we bother about informed, evidence-based decision making. Is there any reason to believe it in any different, in your own area of expertise? It's common, by the way, not necessarily related to health issue, but in every profession, area of expert, informed decision making, evidence-based decision making is lacking. So, but there are challenges, of course. It's not as easy as I'm talking, but time, inability to access, culture, resistance are some of the problems. Anyhow, to conclude, as a keynote speaker, my objective is to bring some issues to discussion, and I want to appreciate Oromia Health Bureau to prepare such very important and timely conference. Thank you. Have a nice time. Thank you again.
Dr. Garramoo guddaa galateeffannaa gara bakkee isaaniitti deebi'uu nuuf simna. Kabajamtoota hordoftoota keenya as galma kana keessatti argamtanii fi akkasumas karaa miidiyaa hawaasaa Biiroo Fayyaa Oromiyaa, Feesbuukii, YouTube fi akkasumas weebsaayitiidhaan tamsaasa kallattiin simbangaa jiru kun konfiraansii qorannoof qo'annoo marsaa 2ffaa Biiroon Fayyaa Oromiyaa qopheessedha. Konfiraansiin kun guyyaa borus itti fufaa. Dhimmi fayyaa dhimma lubbuuti. Dhimma lubbuu murteessuuf ammoo waa hojjechuuf qorannoof qo'annoo saayinsii irratti bu'uureffachuu qaba jechuudha. Kanaaf Biiroon Fayyaa Oromiyaa marsaa jalqabaa bara darbee qopheessee jira. Marsaa 2ffaan kun ammoo kan guyyaa har'aati. Bara darbee namoota qorannoof qo'annoo gaggeessan kan biyya keessaa qofatu hirmaate. Kan baranaa ammoo kan adda godhu marsaa 2ffaa qorannoof qo'annoo namoonni gaggeessan, hayyoonni qorannoof qo'annoo fayyaa irratti gaggeessan akka addunyaatti biyyoota garaagaraa jiran kan hirmaachisedha. Kan qaamaan asitti argamuu hin dandeenye viidiyoo konfiraansiin nu waliin kan hirmaatan. Kanaaf hundi keessan asitti nu argamu keessaniif guddaa sin galateeffanna.
We thank Dr. Garramoo Huluqa, President of Oromia State University, for his wonderful keynote speech. And as we have told you, this what makes this one, especially this one, is an international conference whereby the international researchers are participating on the issue of the health. So this is what makes the space. And now we have next speaker. Our next speaker is from the WHO. We have WHO representative Innocent Comcage. Please join us to welcome Innocent.
Bakka bu'aa dhaabbata fayyaa addunyaa Innocent Garwaltajjiitti affeerraa nuuf simadha.
Thank you, sir.
Thank you. Excellency, Honorable Minister for Health, Dr. Leah Tedessa, Excellencies, Head of Oromia Health Bureau, senior government officials here present, members of the academia, partners, ladies and gentlemen. I thank you very much for this invite and bring for you greetings from the representative of the World Health Organization, who is unable to be here because she has been in the regional committee meeting. The topic of today is particularly critical, tackling health service delivery bottlenecks through evidence-informed decision making. And I think the world can attest to this. This question has been discussed in many major forums. At the PHC conference in 1978, world leaders convened to discuss this. In the Millennium Development Summit, in in 2000, and more recently in the UN Sustainable Development Summit in 2015. In all these, world leaders committed to tackle the main bottlenecks that affect the health of the population. The Sustainable Development Goal particularly brought in the issue of tackling, delivering universal health coverage for all people of the world by the year 2030. A lot of progress have been made, but despite the progress, many bottlenecks still exist. To date, 3.5 billion individuals still cannot access essential health services, and yet 40% of the spending is considered to be lost to inefficiencies, and also 1 in 10 individuals are receiving hospitalization still do not receive desirable outcome from their care. Ladies and gentlemen, to mention that norms and standards is core to one of the key functions of the World Health Organization, and central to this is the issue of evidence generation and therefore use. So the demand for evidence is really central to delivery of quality health services to the population of the world. And this is important in tailoring the interventions to local context, in identifying and evaluating barriers, and in formulating and the implementation of high-impact strategies. Today's conference focuses on tackling evidence-based information as a means to achieve, to address hurdles in the service delivery. It is therefore core to utilization of credible evidence generated from various sources, research, professional practice, patient experiences, and also data from local information that must be available if evidence is to be generated and used appropriately. But is sufficient evidence available for the local context that is prevailing at the moment? Are the researchers and the policymakers on the same page? The answer is yes, but also no. There is enormous availability of evidence, and ideally, if they were utilized, many of the bottlenecks could actually be addressed. But the researchers and the policymakers are not speaking the same language. Policymakers particularly are concerned that many of the evidence are too detailed, too complex, too technical, and also they lack timelines. And therefore, to address this, I cannot go in depth in all, given the time that's available. But to address those two main issues seems to come out clearly. The issue of translation of the evidence and the issue of design elements needs to be addressed. Are the messages that we are delivering from research appropriate for the target audience in terms of contents? Is it packaged in a way that can be understood by the policymakers? Is it appropriate in length and in the way, the simplicity that the policymakers require? All these have to be interrogated if we are to achieve much of what we are getting from the evidence that is being delivered. Let me take the opportunity to thank again Oromia Health Bureau for organizing this conference. And I can assure you that from the WHO side, every endeavor to discuss and find mechanisms to utilize evidence is really most appreciated. I thank you very much.
We thank Innocent Comkesh, representative of the WHO, to the program, and thank you for your message, sir.
Biiroon Fayyaa Oromiyaa tajaajila fayyaa waliin ga'uura darbe qulqullina irratti xiyyeeffachuu barbaada. Kanaaf ammoo saayinsiin deeggaruu barbaada. Konfiraansiin qorannoo Qo'annoo Marsaa 2ffaa kunis kaayyoon isaa kana. Murtee sirrii ta'e ragaan bu'uuree godhachuudhaan tajaajila fayyaa fooyya'aa ta'e kennuuf kan kaayyeeffatedha. Biiroo Fayyaa Oromiyaa konfiraansii addaa akka kanaa qorannoof qo'annoo namoota gaggeessan hayyoota garaagaraa hirmaachisee kanarratti xiyyeeffachuu isaatiif guddaa galateeffanna.
To use our time properly, now I call upon our next speaker. Our next speaker is UNICEF representative to this program, Dr. Ngozi Kennedy. Please join me to welcome Dr. Ngozi Kennedy.
Bakka buutuu UNICEF Dr. Ngozi gara waltajjiitti affeerraa nuuf simedha.
Your Excellency, Honorable Minister Dr. Leah Tadasi, Excellencies, Head of the Oromia Regional Health Bureau, Dr. Mengistu Bekele, other Excellencies here represented, senior government officials, colleagues from sister agencies, our esteemed religious leaders, all protocols observed, ladies and gentlemen. First of all, I would like to thank the Oromia Regional Health Bureau for inviting UNICEF to participate in this important event and to make a keynote address. On behalf of myself, I want to congratulate the team for organizing this conference entitled Tackling Health Service Delivery Bottlenecks Through Evidence-Informed Decision-Making. Evidence-informed decision-making is an innovative approach to health system strengthening, which aims to make research an integral part of health service planning and delivery. It is critical for improving health services delivery program planning and the quality of health services. UNICEF health goals are to ensure that every child survives, thrives, and achieves his or her full potential. In order to achieve that, it is necessary to identify research questions from real-life implementation bottlenecks and challenges, and then ensure that program managers, decision makers, and the leadership is engaged on the entire process, of course in collaboration with academicians and local researchers. The use of research finding informed by field experience and relevant contextual evidence are also crucial for policy formulation and for the improvement of services and the health system as a whole. We in UNICEF are a firm believer in addressing these key research questions, in documenting and synthesizing field experience to provide the evidence that is necessary for informed policy and practices. We have therefore partnered with the Oromia Regional Health Bureau and other partners to conduct implementation research and support evidence generation with a focus of improving quality of health service interventions in Ethiopia. To mention a few of our recent collaborations, we have collaborated with CDC and the Oromia Regional Health Bureau to conduct the assessment of strategies to address immunization service delivery challenge in urban settings. We have supported an MCV2 barrier analysis and also a study on the critical elements of the supportive supervision needs of healthcare workers. As we believe that data that is generated at local level is critical for informed interventions, we continue to support process-level data collection, analysis, and the use of local evidence for action. This includes rapid community surveys to estimate the true local coverage of vaccination, knowing that our administrative data do not show the reality due to challenges with the denominator and suboptimal quality. We continue to support local program officers and supervisors to verify data from diverse sources, conduct session monitoring, and community engagement. This local evidence and generation and the use of local data has been demonstrated to improve the quality of services. UNICEF remains committed to work with the Ministry of Health and the Oromia Health Bureau and other partners to strengthen the capacity of service providers, mid-level managers to be able to collect evidence and use quantitative as well as qualitative data for decisions related to the well-being, survival, and success of women and children in Ethiopia. I wish us all an engaging and productive conference, and thank you for the opportunity.
Guddaa galateeffannaa keessummaan keenya ittaanuuf nuti Harvard-irraa Profeesar Tsinu'eel gara waltajjiitti affeerraa nuuf simadha.
Now we would like to invite Professor Tsinu'eel Girmaa from Harvard. Please join me to welcome to the stage.
Good morning, everyone. First of all, I would like to ask for your apology to be very informal in my dressing. I see here everyone is well dressed, respecting the event. But I just came from a trip, so I had to rush to this event. So I hope I will get your apologies. So I'm always excited to be in this type of event, particularly organized by Oromia And as I always say, I'm happy to see the community here, representatives of the community, represented by Hadasiket and Abagada. So that makes it really peculiar in all the events. I have never seen a conference where the community is represented in one way or another. So I always would like to appreciate and start with that appreciation. Thank you. So I would like to frame my opening or keynote address with a very recent event that we all have been observing, that is, or watching, the 19th World Athletics Championship. I'm sure you have seen at least one of the games, right? And in this game, I have two peculiar events I like very much, and I take as an analogy or a metaphor for my work in evidence to policy making. One is marathon, and the other one is 100 meters. So my speech is about the last 100 meters. Of course, you cannot talk the last 100 meters without talking about marathon. Marathon is 42 kilometers. So availing evidence until you reach to the policy level is a marathon. It's very, very grilling. It takes a lot of time. It takes a lot of energy. It takes a lot of discipline. But the last 100 meters is not also less important and less effortful. I quote Usain Bolt said, to finish the last 100 meters with less than 10 seconds, I trained 4 years. So he trains 4 years to run less than 10 seconds. Can you imagine that? It doesn't make sense, right? Why would you run 100 meters over less than 10 seconds and then prepare for 4 years? So what does it require? For me, putting evidence, whatever its source is, research, excellence from expertise, clinical trials, observations, best practices, is like running the last 100 meters. So, still dwelling on that framework or frame of analysis, what does it take to finish the last 100 meters? You need at least 3 basic things. You need a proper structure. You need the proper and appropriate capacity. The last one, probably not the least one, is culture, an excellent culture. So that is what runners do. They are the most disciplined individuals among sportsmanship. I'm not biased because I like running, so maybe I'm completely biased. But I find athletes to be having personal integrity, a very nice personality. Look at Haile Gebrselassie. Look at all the elite athletes. They're known for their personalities. Okay? So that shows you culture is important. So how do we bring that culture into our institutions? Okay. So evidence to policy, if you want to have the culture, you need to have a marriage between science and the political decision-making process. So what is the discipline in science? What is the culture in science? I can give you one. It's organized skepticism. That means questioning everything. You don't accept anything without questioning. Is that the same culture in political decision-making? Do you accept everything without questioning? Yes and no. But we need to come to the midway. So science will say, question everything before you make a decision. Go through rigorous p-value modeling, see if the p-value is less than 0.5 and so on. That needs a very strict and mandatory procedure. That's the culture of integrity. But in our day-to-day life decision-making, we don't look at p-value. I'm sure Dr. Lina will not look at p-value when she's making a policy decision. Whether it is a p-value is, I don't know. So our values differ. The science is about p-value, but the political decision is about public serving value. It is communal decision-making process. For me, this mechanism is representing the community, which is represented by our fathers, mothers, making the decision on behalf of them. So that doesn't really always need science. So we have to keep that in mind. So when you bring the two, you have to come to the middle distance. That's what we have been doing the last 7 years. As not, I wouldn't really call myself as a partner or we are just part of the system, one wing, one aspect of the system. Like we've been working with the ministry, we've been working with Dr. Mengistu and his team. So it took us a long time to understand how the system works, and then also to cross, to pass over our thinking, way of thinking to the people in the system. So we have to come to the middle ground. There are always deadlines to make decisions. There are always emergencies. But there is no emergency clinical trial. You do a clinical trial, it takes 3 years, yes. Sometimes 4 years, sometimes 10 years. But decisions have to be made now. If there's an outbreak of measles, it has to be made decision by now. You don't have to go and see, is a vaccine, this and that, okay? So we have to come to understand to that situation. There is this culture. So let's come to this middle ground. Always the middle ground is nice. I like the middle ground, not the two wings. The second is structure. The structure, I'm just giving you a flavor of what I wanted to pass, as well. I can spend the whole day speaking here. The structure is, you need structure, formalized structure for things, because it's a framework. If you look at the human body, we have the organs, the brain, which are really, really very important. But you cannot, you need some framework to hold them together. So you have the frame, the bone, to hold them together. Our lung is surrounded by the ribs. Probably, rib fracture is the least important thing, but it is the most important thing for the lung, because the vital organ is the lung, but you need the structure. So you need that type of organized system. So what we tried to do, for example, in terms of facilitating evidence use in our system is establishing some platforms. For example, this is one of the structures, the platforms, to get all the stakeholders together, share ideas, okay, see their faces. Maybe you have seen the paper of X 100 times, I've read it 100 times, but I haven't talked out to that person. What is his values? What is he thinking? What does she look like when you talk to her? What can I learn from her? So these are the type of structures. So I'm really happy to have this type. They are expensive, I know they are expensive, you cannot run it every month, okay? Even a yearly one is, a very tough thing. It takes a lot of resource and organization skill. But we can also scale it down, the same thing. So what we did, for example, in terms of structure and platform is bringing the researchers and the program people together in a form of brown bag. For example, in the ministry we have the Agalgal session, in Oromia we have the famous Gala session, in Amhara we have the famous Sink session. This is, a very tiny innovation, but it's just very critical, It adds value, because the researchers come to the office of the programmers. You don't ask the programmers to go to a hotel. You just come to their office, present your finding for 20 minutes, 30 minutes. You might think that, the beneficiaries are the programmers. What we found is the researchers are the beneficiaries, in a way, because it's a two-way learning. No one comes empty-handed, and nobody goes without empty-handed. So it's a platform for exchange, and it's always capacity exchange. I always emphasize on the exchange component. Nobody comes empty, nobody goes empty, okay? So these are the type of structure we need. So the SAP, the RAC, these are platforms, structures to facilitate. They are not easy to establish, they are not easy to run. They are really important, and they are excellent experiences. I've just been to a place where these type of things have been discussing, and when I was telling them our experience, they were saying, wow, is that written? Where can we find the literature? I said, no, it's not written. That is our strongest weakness, right? We don't write what we do. That's our strongest weakness, right? The last problem, not the least, is capacity. You need the capacity. As I said, Usain Bolt needs the capacity, the mental capacity. Have you seen his physique? Yeah? I cannot be a 100-meter runner. Maybe, if you have looked at the Jamaicans, Fraser is my favorite. She's so tiny, but she runs like a hell. So you need the capacity. So it doesn't mean also, it could be also, mental capacity, the personality. So that is what we tried also to build. It doesn't come easy. So you need a constant interaction. You have to be also innovative, and really not really fall back to this the usual form of preparing workshops, after workshop after workshop, on meta-analysis, systematic review, and so on. These are not really that much effective. It should be hands-on training and with impact. So I can tell you a lot of examples that we've achieved through this capacity building. So let me finish by just summarizing what I said. So you need to run the last 100 meters, but you need to have the structure, the capacity, and the culture. And we are here all together. There is no one doing it single-handedly. Thank you very much.
Thank you, Professor, for the wonderful message, and it was professional and inspirational. Now I would like to invite Mr. Chala Damana, Chief of Staff of the Health Bureau. Then he will invite the Bureau Head, Dr. Mengistu. Then, all right, now I think the program has been changed. Now I will directly invite Honorable Dr. Mengistu Bekele, Head of Oromia Health Bureau. Please join me to welcome Dr. Mengistu Bekele.
Hoggana Biiroo Fayyaa Oromiyaa Dr. Mengistu Bekele waltajjii irratti argamaniiru.
Akkam jirtu baga nagaan dhuftan እንኳን ደህና መጣችሁ ሰዓት ስለሄደብን የፕሮግራም ለውጥ አድርገን ይቅርታ Excellency Minister Dr. Liyaa Taaddasee and guest of the day kabajamtoota abbootii gadaatii fi haadholee siinqee Dr. Garramoo Hulluqaa President of Oromia State University Dr. Geetaachoo Toleeraa Deputy Director General of Ethiopian Public Health Institute, Dr. Ngozi Kennedy, Health Section Lead at UNICEF, Innocent Komaki, Field Hub Lead of WHO, Professor Sunil Girma, North Harvard Country Representative, Honorable Federal and Regional Government Officials, respected heads and delegates from development partners, respected researchers and participants of this conference, ladies and gentlemen. First of all, I would like to welcome you all to this colorful second annual scientific research conference organized by Oromia Regional Health Bureau. Baga nagaan dhuftan, እንኳን በደህና መጣችሁ. Since 2019, Ethiopian health system has been challenged by different pandemics and local disease outbreaks like COVID-19, malaria, cholera, drought, flooding, food insecurity, health supply stockouts, and conflicts. You all remember these. This forced us to rethink the way to achieve universal health coverage, because universal health coverage is an aspiration of every country. By now, our Prime Minister, His Excellency Dr. Abiy Ahmed, has brought one new thinking, which is named Fatarana Fitnat. Aritifi Kalakan. This is the only way out that we can manage the challenge that we are facing recently. In addressing this multifaceted challenge and narrowing the gaps between health need and supply, Oromia Regional Government has invested in system strengthening to be only realized through the engagement of all stakeholders and empowering the lower level government structures. We have a commitment, compassion, collaboration, and community-centered core values to serve our respected communities. Most importantly, our regional Tajajila Lamumma campaign has played a fundamental role in boosting our regional commitment. In this, the role of private and professional association is immense. We want to value your contribution towards Tajajila Lamumma. Ira debe singalateeffachun barbaad. Waldaalee fi dhaabbilee dhuunfaa gaheen keessan baay'ee guddaa waan ta'eef. I would like to thank all in this room as you made a collective effort to bring the substantial change in public service provision, which let us win the Presidential Award of Oromia this year. It has been said quite many times, we stood third among all sectors in the region. but I want to extend my appreciation to all my service providers, which is about 90,000 health professionals in the region. So this award is yours. Thank you very much. Despite the concerted effort to provide comprehensive health service to the community, as per the WHO recommendation, Oromia Regional Health Bureau is only providing less than 50% of the services to be given for the community. Because the OPD attendance per capita, as per the WHO recommendation, is said to be, said to be 2 to 3 times per capita, but ours is almost around 1. It shows we have a lot to work on and at least meet the expectation of the community. The existing platforms that have been established following the regional health information strategy has taken us a long way from traditional practices. This has been practiced both at the policy as well as at the program implementation level. This has taken us to a path of owing regional health research and translation guideline, which identified and recommended the existence of this kind of regular scientific research conferences. The primary objective of such regular conference is to bring together stakeholders to share available evidences, exchange new ideas, and align the region's various health and health-related activities. This platform strengthens the collaboration between universities, research institutions, and other research-engaged partners in evidence generation and translation into action. In this year, the Bureau organized the second annual health conference with the theme of tackling healthcare delivery system bottlenecks through evidence-informed decision-making. I believe this would bridge the evidence generation and translation systems and improve the region's evidence generation and translation culture in the country. We'll use the output of this platform for mobilizing stakeholders, engaging the regional government in evidence-based identified interventions, and mobilizing resources from donor organizations. With this, I would like to call on our development partners to stand with us in the implementation of crafted initiatives in solving the existing bottlenecks for reducing maternal and child health mortalities, improving child nutrition and adolescent health, strengthening the regional health financing landscape, and instituting public-private partnership, tailored research investments on selected sustainable development targets. Finally, I would like to express my heartfelt thanks to those who took part in organizing this conference, provided financially as well as technically, for the support of realization of this event, and wish you a successful today's scientific deliberation. I thank you. በመጨረሻ የተከበሩ ዶክተር ሊያ ታደሰ የጤና ሚኒስቴር ሚኒስትር ወደ መድረክ መጥተው የሥራ መመሪያ እንዲሰጡን በአክብሮት ጋብዛለሁ። ተቀበሉልኝ።
መንግስቱ ላይ ያስቸግረኛል እንግዲህ ቁጭ እንዲል ነበር። አካምልተኒ ታደራችሁ የተከበራችሁ የሀገር ሽማግሌዎች፣ አባገዳዎች፣ አደሲንቄዎች ንግግሬን ያው ልክ እንደ ሁሉም ተናጋሪዎች ያው በእንግሊዝኛ ስላደረኩ ወደ ዛሬ ሪቨርት አደርጋለሁ። Your Excellency Dr. Mengistu Baqqala, Head of Oromia Regional Health Bureau, our distinguished leaders of federal institutions, regional institutions, university presidents and families of universities, researchers who have come from different academic and research institutions, our development partners, UN agency representatives, all invited guests and presenters for this conference. My great pleasure to be here today on this very important conference deliberating on evidence, which is the second annual research conference of the Oromia Regional Health Bureau. I would like to start by congratulating the Oromia Regional Health Bureau for this successful second annual conference, and also for the recognition that the Bureau has received based on its performance from the region, from the regional president. When we see our health system of our country, to date we have registered remarkable achievements on different fronts, from significantly decreasing child and maternal mortality and preventing and controlling infectious diseases, to expanding access to health services to grassroots communities in the last couple of decades. But while we celebrate these gains, we are also aware that we are challenged by several persistent and emerging issues and public health concerns. These include the emerging and re-emerging of different diverse public health emergencies that Dr. Mengistu earlier outlined, increasing of non-communicable diseases, issues of quality and equity related to health services delivery, limited financing for health, among the different challenges. We believe that in the past years, the implementations have brought a lot of change, and most of the relatively easier solutions for this challenge and others have already been implemented. And what's ahead of us are much more complex health system challenge, demanding more innovation, more research and evidence generation to support the different options of interventions that we need to design for our decision making at national and subnational level. That's why I'm very pleased to be here at the opening ceremony of this second health research conference organized by the Oromia Regional Health Bureau under the theme Tackling Health Service Delivery Bottlenecks Through Evidence-Informed Decision Making. This conference aims to explore existing evidence regarding health service delivery status and also to reshape future orientation of key stakeholders in advancing new evidence generation, and not just generation but also utilization for the improvement of our health system. And I'm particularly happy that it focused on health service delivery, because ultimately the investments we make in our health system, their fruits are seen in how we deliver services, be it investments in health workforce, in supply chain, in financing. All these ultimately are seen on how we deliver the services to our communities, which will ultimately result in the outcomes. So both the gaps and the successes ultimately are seen in this, and this is a really critical issue that makes this conference a big opportunity to address this issue. At the national level, the ministry is investing in supporting data and evidence generation through different efforts, from investing in our national health information system from the grassroots health post level to up to the ministry level through our DHIS2 and other digitization in interventions, and also investing in its own research institutions, the Ethiopian Public Health Institute and Armor Cancer Research Institute, and also working in collaboration with different academic institutions in the country. But we had identified a gap we need to address to facilitate coordinated health research evidence generation, synthesis and priority setting, as well as its use for decision making and policy making. Even though, of course, we had different ways of how we set priorities and use the generated evidence for decision making, those were the two critical issues we identified as gaps in terms of having the need structure to address this. These are the two ends of the research continuum. priority setting, we have all the process in between of generating the evidence, and then at the end, the use of those evidences for policy and decision making. So to address this in a more institutionalized and structured way, as mentioned earlier, we have recently established the Policy, Strategy and Research Lead Executive Office under the Minister's Office, under my office at the Ministry of Health. And we believe this will play a catalytic role in setting national and regional health research priorities, because we need to identify priorities that are key bottlenecks that needs to be addressed, and then of course the subsequent use of evidence to inform policy and practice. In that regard, we have recently embarked in doing a national research landscape analysis to help guide our roadmap in including the capacity building efforts and the different interventions we need in the efforts of research. Carefully crafted health research conferences such as this one they provide excellent opportunity in different ways. One, it helps in deliberating on pressing challenges of our health system, informed by contemporary evidence and what new evidence that needs to be generated. It's also a great opportunity to create more strong bridge between researchers and health program managers. I really want to emphasize this point because there is a huge missed opportunity we see in our health system, in our overall system, which can be developed between partnership between academic research institutions and health program managers, be it at regional health bureau level, zonal, and even at ministry level. And there are good examples that we are now seeing. One example I can cite is the capacity building and mentorship program that many of you know, CBMP, which is a collaboration between the Ministry of Health, regional health bureaus, and universities, which started with 6 universities across the country, which focuses on creating model health facilities and waradas through implementation in data quality and use of health information for decision making, which is now we are expanding to even other health programs in addition to data and health information. We are seeing very strong results because this has 2 impacts. The health program managers know what are the real challenges in the health system. And those within universities, academic research institutions, they have the capacity of research, data analysis, and the needed capacity to generate the evidence. But they may not have the same understanding of health system challenges that the health program managers have. So when these are working together, it creates a win-win opportunity for both sectors, creating really impactful solutions for the health system. So I hope this conference will also be an opportunity to expand such partnerships and collaborations and creating networking in the health system. And also, of course, it will be an opportunity to identify in research evidence gaps identify the gaps that we have in research evidence, especially for the different challenges we have highlighted earlier, so that we can really design the right program. So with this note, I would like to encourage you all to really actively participate and extract the best out of the research presentations, panel discussions, and side meetings, and we really look forward to utilize the outputs that will come out of this conference in our future designs and interventions for the health system. Before I close, I also would like to invite you all for the upcoming international conference in primary health care that the Ministry of Health, in collaboration with the International Institute for Primary Health Care and Johns Hopkins University, that we are hosting next week. The in-person participation may be limited, but it has virtual participation, and we are announcing it repeatedly on our social media. So hopefully this is the first of its kind, focusing on how we strengthen primary health care to achieve the commitment we have to reach universal health coverage. So I would like to invite you all for that conference. And once again, thank you very much for this commitment. I would like to express again My sincere appreciation to the Oromia Regional Health Bureau for this commitment and all who have supported this effort, and wish you a successful deliberation throughout this conference. Thank you very much.
We thank the Honorable Minister and His Excellency Dr. Mengistu Baqqala, the head of Oromia Health Bureau. And now we'll directly go to the tea break. First, accompany our guest of honors, then the rest will follow then.
Keessummaa keenya kabaja Ministeera Fayyaa Dr. Liyaa Taaddasaa fi hoogganaa Biiroo Fayyaa Oromiyaa Dr. Mengistu Baqqala nuuf gaggeessaa guddaa isaan galateeffanna. Kan hordofaa jirtan Konfiransii Qorannoof Qo'annoo lammaffaa Biiroon Fayyaa Oromiyaa qopheesseedha. Konfiransiin kun adda wantoota isa godhu keessaa akka addunyaatti namoonni yookaan hayyoonni qorannoof qo'annoo fayyaa irratti godhan iddoo garagaraatti kan irratti hirmaachaa jiranidha. Kanaaf keessummoonni keenya dhuftanii sagantaa kana irratti hirmaattan akkasumas iddoo garagaraa teessanii karaa miidiyaa hawaasaa Biiroo Fayyaa Oromiyaa YouTube, Facebook fi akkasumas websaayitii hordofaa jirtan hundi keessanuu guddaa isin galateeffanna. Konfiransii kun itti fufaa guyyaa boruusi amma sa'aatii boqonnaadha. Sa'aatii boqonnaati waan ta'eef gara boqonnaa.
Now it is tea break or health break, and now go and rest. And it is, as we have said, so this is the second annual meeting, but it is first of its kind because it is engaging researchers across the globe, like we have research from America, from Europe, and elsewhere in Poland. Now just
Tole hirmaattoota keenya egaa daqiiqaa 15 booda akka garagalma kanaatti nuuf deebitan kabajaan isin gaafanna. Yeroo shaayii dansaa qabaadha, yeroo boqonnaa dansaa qabaadha.
kabajamtoota hirmaattota keenyaa shaayii fayyadamaa iddoo poosterii maqaa keessan jirutti waraqaan walii ibsatan waan jiruuf iddoo poosterii maqaan keessan jirutti akka argamtan kabajaan isin gaafan. kabajamtoota hirmaattota yaa'ii kanaa kabajaan gara galmaatti akka seentan isin gaafannaa amma especially yeroo mariin hayyootaa itti gaggeeffamu waan ta'eef kabajaan gara galmaatti akka seentan isin gaafannaa. We urge everyone to get into the hall so that we can begin the discussion session with the researchers. Kabajamtoota hirmaattota marii kanaa kabajaan gara galmaatti akka seentan akkasumas immoo mariin paanaalii akka eegalu kabajaan isin gaafannaa gara galmaatti seenaa. kabajamtoota daawwattoota keenyaa akkuma dura jennee kuni konfiraansii yeroo lammaffaa biiroo fayyaa oromiyaatiin qophaa'e. Kanaaf yeroo keenya akka haalaan itti fayyadamnu warreen ala jirtan ammas gara galmaatti akka seentan kabajaan isin gaafannaa. Dan yeroo kanutti haalaan fayyadamnee sanaan booda warreen waraqaa dhiyeessan paalaan diskeshiniin garaagaraas waan jiraatuuf kabajaan ammas warreen ala jirtan gara galmaatti akka nu seentan isin gaafanna.
Konfiransii Qorannoo fi Qo'annoo Marsaa 2ffaa Biiroon Fayyaa Oromiyaa qopheessee irrattidha hirmaachaa kan jirtan keessummoonni keenya hirmaattonni sagantaa keenya yeroo boqonnaa dansaa dabarsitanii akka dhuftan abdii qabna. Itti fufna sagantaan keenya itti aanu egaa Biiroon Fayyaa Oromiyaa keessattuu tajaajila fooyya'aa ta'e hawaasaaf fayyaa hawaasaa eeguuf tajaajila fooyya'aa laachuuf kanaaf immoo qorannoo irratti hundaa'uu qaba ejjennoo qabuudhaan egaa ejjennoo kanaatiin bara darbe marsaa jalqabaa konfiraansii qorannoo qo'annoo hayyoota biyya keessaa hirmaachisee ta'u kan gaggeesse marsaa lammaffaa kun ammoo hayyoota qorannoo qo'annoo dhimma fayyaa irratti gaggeessan iddoo garaagaraatti akka addunyaatti hirmaachiseeti sagantaan kun kan gaggeeffamaa jiru hunda keessanuu keessattuu hayyoonni qorannoo fi qo'annoo dhimma fayyaa irratti gaggeessitan yeroo keessan beekumsa keessan hawaasaaf fayyaa uummata keessaniif dhimmamtanii gaheen keessan guddaadha waan ta'eef galata guddaa isiniif qabna.
I hope you have been enjoying the program because it is a professionalist program, it is a research conference, and now I'm going to invite Dr. Tezeta Chalon to the stage. Then it is a time for the research presentation and the panel discussion, and I hope you're going to have a great time. Thank you.
Thank you. Thank you, Master of Ceremonies, and thank you, participants. We will have a presentation on service assessment, service provision assessment, and the presenter will be Dr. Tedros Getachew from Ethiopian Public Health Institute. He has a PhD in public health, focusing on the quality of care provided for sick children in integrated community case management. The focus of research has been generating evidence across the health system and reproductive health area, including the evaluation of programs, intervention, and strategy. Currently, he is the director of the health system and reproductive health research directorate of Ethiopian Public Health Institute. Is the lead researcher also. He has an experience of a professional in academic editor for PROS1 and has more than 60 peer-reviewed journal. So I will upon invite Dr. Tedros for his presentation. He will have 15 minutes presentation, and then directly we will enter to the next panel discussion directly without having questions and answers. So thank you and welcome.
Thank you for the introduction. I will be presenting on the national facility assessment, which is mainly focusing on service provision. And can I have the slides? Okay, thank you. So it's difficult for me to look back, okay. And this is actually a second national health facility assessment. The first was conducted in 2014, and with the objective of to answer 4 key questions. The first one is the service availability in the country, and the second objective was to see the specific service readiness at health facility, and the third objective was to see some quality dimensions of the services provided at this facility and the client satisfaction as well as, and we try to see some trend analysis between the two surveys. And this study has been conducted in all regions except Tigray regions. It has 4 questionnaire or modules. The first one is the inventory or audit, which implements or tries to capture data from the health facility in general. The second one is the provider interview, which tries to see the training they have the provider and some clinical knowledge of the provider. In addition to this, we try to see the observation of consultation on exit interview or selected services on antenatal care, family planning, and sick child services. The data was collected between August in 2021 and February 2022, which took around 6 months. And this is actually the facility distribution in the national, and we sampled around 1,400 health facilities in general, but we were able to collect data from 1,158, which makes the response rate about 82%. In Oromia region, we tried to include 291 health facilities, but due to different reasons, we were able to capture around 233 health facilities, which some of the health facilities were excluded because of the facilities were closed, and we were not able to reach or access the facility. And some of the facilities were actually specifically converted to a COVID center, so that we excluded those facilities. And we were actually try to include more than 2,000 client observation and exit interviews for ANC, family planning, and sick child. And we included around 8,000 provider interviews. So I will specifically present the results for Oromia Regional Health Bureau, even though the study was national. So there are actually some slides which is not visible here. So we can see from the graph that this is actually the basic client services in Oromia, and in general among the listed 6 client services, only 1 in 4 facilities in Oromia provide all client services, which includes child vaccination, growth monitoring, family planning, ANC, and STI services. This graph shows that the assessment of sick child consultation in Oromia region, among the observation, we found that only 3% of observed consultation of sick child assessment included all 3 danger signs. We know that the danger signs are these convulsion, vomiting everything, and inability to eat or drink. So that only 1 in 3 of the observer consultation included this assessment, and around 42% or 4 in 10 observed consultations of sick children included an assessment of all 3 main symptoms: fever, diarrhea, and cough. But you can see from the top that 55% of the consultation were not actually undergone or these 3 or any of the danger signs. This is the graph from the content of family planning consultation, and we can see that it is relatively good that most of the clients were undergone the physical measurements, but from the below we can see that none of the providers in Oromia asked all risk medical histories, which includes like the about any chronic illnesses they had, or any symptom of STI, or their smoking habit of the mother. This graph indicates the observed NC clients in Oromia, and it is relatively good, even though all clients should take specifically on their first visit should undergo the routine laboratory diagnostic tests, but we can see from that only half of them were undergone the routine tests, and in client history taking, only 1% of the provider in Oromia assessed all client histories. This is actually the HIV testing in Oromia. 59% of the facility provide HIV testing services, and 15% of them provide ART services. And we can see that among the facilities that provide ART services, most of the laboratory diagnosis services were not available, specifically the CD4 count and the chemistry tests like renal and liver function tests. 81% of the facility in Oromia provide diagnose and treat TB treatment, and 54% of the facilities diagnose and treat MDR TB. And this is the result for the non-communicable disease, and we can see most of the facility provides non-communicable disease, but only 20% of the facility, around 20% or 1 in 5, provide mental illness and cancer services. We also ask the provider their ability to correctly classify certain selected diseases, and we found that the diagnostic accuracy for tuberculosis is relatively good, 88%. But we can see that malaria with anemia were not identified by most of the provider, which is a quarter. And the maternal and neonatal health is it's relatively good, and the average knowledge score for the provider in Oromia is 64%. And this is actually not specifically for Oromia. This is the result for the national in Ethiopia. And we try to see some trend analysis between 2014 and the current SPA. We can see from the graph that most of the client services do not progress very well. An asterisk indicates a significant chance between the two surveys, but we can see the antenatal care even decline in the current survey. The orange color is the current one, the aqua color is the previous one. We can also see that for the basic amenities, this has been actually significantly increased between the two surveys, especially on electricity and client latrine and communication equipments. Next slide. The rest of the slides are also trend analysis on certain laboratory services, even though it seems that the laboratory services has been relatively inclining, but it was not statistically significant, so that now this report, actually I have been presenting this specifically for Oromia, and as we all know that SPA data is rich and it has more than 1,000 variables. We simply describe the current situation in terms of service availability, some quality aspect and readinesses, and we encourage researchers to dig further why these results are not inclining as expected. Yeah, actually the slide is not working, but it is the remaining slides are on equipment and laboratory services, but the trend also indicated that it has not been increased as expected. Thank you very much.
Thank you, Dr. Tedros, for your nice presentation. I think the presentation we have attended is helpful to see about the findings of service provision assessment, particularly to the region. So as most of the programmers are around here in attending this program, I think you may use hereafter the findings of this assessment for your program intervention and activities. So I would like to thank the APHI and Dr. Tedros for his presentation. So by saying this, the next one, the next session is a panel discussion. The panel discussion will be titled Quality Data for Better Health Service Delivery, Evidence-Informed Decision as a Base for Universal Health Coverage. As you know, there have been an ongoing concern regarding implementing universal health coverage, particularly in resource-poor settings like Ethiopia, especially data handling, data management, and evidence-based decision in promoting universal health coverage. The standard approaches to achieve universal health coverage often include framing problems, identifying and gathering data and evidence, and also designing programs and policies. So it's important to look for the universal health coverage and evidence-based interconnection based on the experience for Ethiopia and particularly to Oromia region, and we will have also a case from hospital. So we have 5 panelists for this panel discussion. So I will read for their biography, and I will invite them to come to the podium later, next to that. So the first panelist is Professor Isaias Kabada Godina. His educational training is Doctor of Medicine from Jimma University, Internal Medicine Specialist, Diploma in Tropical Medicine, London School of Hygiene, PhD in International Health from Maximilian University, Munich, Germany. And he has served as Jimma University at various leadership positions as a medical doctor, as a chief executive director, and received multiple honors and grants from national and international organizations. You know, he has ample experiences in different activities in the health system of Ethiopia, and he is also a membership for international associations, professional associations, and also national associations. He served as also advisory panel for communicable disease when it comes to particularly to the Oromia Regional Health Bureau, and he is editorial board of Ethiopia Medical Journal, and an executive committee of Ethiopian Society of Internal Medicine, life member Ethiopian Public Health Association, and executive of Center for International Health. Is a member at Leuven Maximilian University of Munich, Germany. By saying this, I would like to invite Professor Isaias Godina to come to the podium. Please help me to welcome him. Okay. Maybe to add something, as you know, he is much experienced. He has more than 70 peer-reviewed journals, so he's a well-known researcher. So the second panelist is Mr. Wubishet Demboba Midisa from JSI DUP project. He's a project director. He has a master's degree in public health from Marsaa University and more than 50 years of experience working in health sector in different capacities, and has an extensive experience in designing and implementing health information systems, health sector, strategic and operational plans. And he has been an instrumental, particularly Ethiopian transition from the fragmented and disintegrated data system to the current health management information system. He also worked as a public health practitioner and manager of health center at the district level. He has then worked as paper-funded international NGO for more than 11 years, and designing, leading, monitoring, capacity building, and implementing the health management system, focusing on policy and operational and strategic planning at the system. So since 2019, he has worked in different technical supervisory and leadership capacities with the JU-DUP project to support the Ethiopian Ministry of Health's plan to realize an information revolution through the cultural transformation of data use, digitization, and HI governance. So he has tremendous experience working closely and in partnership with Ministry of Health, Regional Health Bureau, local universities, and development and implementing partners. So I welcome Mr. Wubishet Demboba. Okay. Thank you. So the good thing is we have variety here. I will call to Ms. Firmai Bogala from EPHI. She is a public health professional and researcher who has practiced public health for 10 years. She has worked in post-clinical and non-clinical health settings. Throughout her professional years, she has worked in primary health care provision, monitoring and evaluation, health programs, public health research, evidence-informed decision-making, and capacity building. Firmai holds a master's degree in public health and is a director of the Knowledge Translation Directorate at the Ethiopian Public Health Institute. She is responsible for leading and executing various projects on translating scientific evidence for evidence-informed decision-making in health. She has produced and co-produced more than 20 peer-reviewed publications and evidence synthesis products. Firmai is interested in exploring contextualizing approach for scientific evidence used in health decision-making for the good of the community. So we will take experience of this culturalization of the decision-making by using evidence from her. I think we will get something from her, so I invite her to come to the podium. Please applaud for her. Thank you. So the fourth, but our own Lemesa Tadessa Amanti is the fourth panelist. So his educational background is MS in Jimma University, Health Monitoring and Evaluation, and BC and Medical Laboratory. Currently, he is a Policy, Plan, Budget, and Monitoring and Evaluation Directorate Director. And he has served as various positions and Regional Health Information Monitoring and Evaluation Team Coordinator, Chief Executive Officer at Shambu General Hospital, Laboratory Team Leader and Clinical Laboratory Expert. He has also a membership for different professional member associations as a project term and evaluation researcher, or Oromiya Health Professional Association a member, Ethiopian Mentoring and Evaluation Association is a member, and also different consultant services and others. He has also worked in several ways, like liaising between the CBA trial assessment data collection team, respective regional health bureaus and Warada administrations, and also participate in resolving any possible administrative and facilitation challenges of data collection teams during the field, and other several experiences related to monitoring and evaluation. So I also invite Mr. Lamesa Taddasa to the stage. Okay, thank you. So the fees is Dr. Solam Bakala. He's a doctor. He has a doctorate degree in medicine from Wolaga University. Has also a TOET training on quality improvement. Currently, he is a CEO at Metal Comprehensive Specialized Hospital. He was working as a clinician and quality officer for the past 3 years at Nakam. We have a young at the stage to get the experience too. So I invite Dr. Solan Bakala to come to the podium. Okay. Thank you. So our format for this panel discussion is we have our panelists here. We have a presentation for brief time because our time already ran out. So I would like to limit the time, only 5 minutes for each presentation. The PowerPoint will be displayed soon, so they know their sequence. They will present each of them. Then we will follow with 2 minutes question, and then the stage will be back to the audience to have a question and answer or a discussion then after. So we will be strict enough because of the time, and so try to manage your time as per your slides. Would you please display the first? Yeah.
Thank you, Dr. Tizta, for the gentle introduction. My name is Richard Demboba. You know, what I'm going to present is the Ethiopian health system, and particularly the Ethiopian health information system movement towards addressing universal health coverage. This should have been better presented if by someone from the ministry. I know the coordinating committee tried that one, but they couldn't manage to get one. And as a data partnership project that works closely with the regional health bureaus and the ministry, it's a great honor for me to present it for such a crowded audience. Slides, please. For time's sake, I think I have to move on, right? We don't have as such so much time. For a quick introduction, as you all know, the Ethiopian health sector transformation plan, be it the previous one or the current, and including the development and investment plan, have this overarching goal of improving the health status of the population. And within this framework, there are 4 major goals that the health sector want to achieve, and one of which is accelerating progress toward this universal health coverage. And in line with this, the monitoring and evaluation framework of the country and the monitoring and evaluation strategic plan of the country also, given a high attention toward this measuring universal health coverage to the engine of primary health care. So we have developed, I don't think they got the presentation, we have developed a framework which is customized from global standards, which has all the health system components, the data source for measuring the key indicators, and indicators in terms of output, outcome, and impact level, and also the principles that we use in ensuring that the MN is stable and able to measure health system performance. Okay, so as you all may know, the Ethiopian health system follows an integrated approach, and likewise, the MN system that we have is also integrated. So don't expect me to speak only about universal health coverage, because whatever we do to improve the health system in general, and the health information system in particular, talks about the universal health coverage too. So the country's progress so far, I will try to map it under 4 major thematic areas. And the first one is around leadership and governance. And as I said earlier, the strategies that we have, the bigger one, and the HIS specific strategic plan that we have for 5 years, and the digital health blueprint are 2 major strategic points that signifies how the government prioritized health information system. As you all know, information revolution has been an agenda for many years, for the last 2 strategic plans. There are major platforms at the national and regional level, the likes of JSCC, JCCC, JCF, and HS-specific platforms like HS Steering Committee, National Advisory Group, the Regional Advisory Group. And the main reason that we had such platform and forum is for the decision makers to sit and look into the data and make decision towards improving our path and our effort, to realize the universal health coverage. In addition, very recently, advocacy towards the use of data, advocacy against falsification of data is improving so fast, especially over the last couple of years. The introduction of Health Data Week, where managers at all levels, bring this idea and advocate for better data and use. Next, please. And next again. Next again. Next. Exactly. So speaking of data system itself, as you know, Ethiopia reformed the health information system back in 2008, and we moved from a fragmented system to a standardized system. And across the period, there were so many revisions, and the reason why we had this revision is to ensure that the indicators needed to monitor universal health coverage are included, and according to the evolving needs of the health sector too. There are these December's notification and registration around research and survey, what Teddy has just presented, the SPA, SARA, the EDHs, and other different operational and implementation research has been conducted over the years. In terms of digitization, the country moved towards digitizing the numerous health information systems that we have in line with the e-health architecture that we developed. So, shared services like MFR, terminology management, the interoperability layer that we have, and the different systems, including the HIS2, ECHIS, EMR, the supply chain systems, the human resource information system, all are in the process of digitization so that we have the access, the ease, and the convenience to make decisions. In addition, the major platform that we use for data is performance monitoring team. We have this at all levels, and the need and the purpose why we have this whole platform is so that people. Okay. So thank you so much. Is for people to see the key performance indicators that we have, which are aligned with the universal health coverage, make decisions, and strive towards improvement. In terms of, in terms of health workforce, at pre-service level, there are standard curriculums for HITs and health informatics that's developed. The country bravely introduced capacity building and mentorship program. We hope this will, link the industry with the academy. We believe there is a lot of knowledge, a lot of evidence at the academy, and we want to tap into that experience and bridge the gap between the two. Back, please. Anyway. So there is also an in-service capacity building that we do over the years for all right. In terms of finance, the the country tried to mobilize as much resource as possible to the health information system. And the bigger picture is there is an increased share of total health budget from the total government budget. Partly this moves into the health information system itself. Finally, I will come to the major challenge that we have, and we'll leave the stage. In terms of leadership, even though we have these many platforms for decision, criticalness, thoroughness, ensuring that the decision made in the forums are closely monitored, is somewhat lacking. Accountability around data capturing, using data is also a limitation. From the information system itself, even though we have so many digital systems, integrating them to give a common picture around, and making sure that the systems are interoperable is a challenge. There is a big connect between evidence and translating that into policy and action. This forum that Oromia has established is one testimony to reconnect this disconnect between the evidence generated and the action we take. In terms of health workforce, having the motivation level improved, capacity and competence, even number is a challenge, and we will work towards that one. Finance, as I said, the mobilization effort is progressing so well, but we have to mobilize so many resources, because even as you have seen in the ECHIS, mobilizing enough resource is a critical driver for success. And perhaps tapping into resources around program areas where every program that we have, MSH, TB, any, have an immune component, in tapping into that and bringing that resource to HIS will be emphasized. I think with this, I will leave that for the second panelist.
Hello, everyone. So I think we're having a problem with the technology, so it's tricky. So I'll just be talking a little bit more. If it works, I'll try to speak to the presentation as well. So before I start, I want to say thank you to the organizing team for inviting me to speak among these recognized and established professionals. And also there are so many mentors in the audience here today, so it makes me a little bit cautious as well. So since I am from the Ethiopian Public Health Institute and I'm working on knowledge translation, I'll speak a little bit about evidence-informed decision-making and knowledge translation as a whole. But since I have like 5 minutes, I'll be speaking a little bit faster. Okay, so since we are having a problem, I'll just start by explaining what what we are trying to mean by when we say evidence-informed decision-making and its relation with knowledge translation and what we are working on in our directorate as well. So as you know, this is not a new thing for you, but talking about evidence-informed decision-making in a country is about informing our health policies, our health programs that are advised by the best available evidence. So the key term here is the best available evidence. So we have evidence, starting from an expert opinion up until the highest hierarchy of evidence when we go to the systematic reviews or support summaries. So the whole evidence-informed decision-making, especially in the health system, is about using the best available evidence for our health policies and decisions or interventions. So what makes evidence-informed decision-making really important, especially in a country like ours, is that it would allow us to use our very scarce resource in a very efficient and effective way, and to put our money where it really matters and where we can see an actual impact. So where does knowledge translation come in here? So it's about, when we talk about knowledge translation, it's about collating evidence, the best available evidence, and packaging that in a way that is understandable and usable by the decision makers. As you know, our decision makers are really busy people, and as was mentioned earlier by Professor Sonoel, it's not going to matter if we present a p-value or a confidence interval for our decision makers. It should be something that is understandable. So this is where the knowledge translation key or the knowledge translation concept comes into play, and it's about synthesizing, collating, and packaging an evidence that is usable by our decision makers. So when we bring, When we talk about evidence-informed decision-making in a country, to say that we have an ecosystem of EIDM that is functional, we have to look into this 6 building blocks that is actually produced by the WHO. So this has been also mentioned earlier in the keynotes. So as you can see, one of the things that we should look into is the governance in a country. So this is linked to the policies that we have, the proclamations that we have, and the structures that we have. Are they really supportive of knowledge translation? Are they really supportive of evidence-informed decision-making? And the other thing that we should look into is the standards and the processes that we have. Do we have tools? Do we have standardized knowledge translation tools? And following by that, we have to look into the leadership and the commitment. Are our leaders really committed to the idea of knowledge translation and EIDM? And do we have champions that are really advocative of this issue and that they can push the idea of EIDM in the health system? And followed by that, we see resource and capacity building that has been repeatedly mentioned earlier. This is, a cross-cutting issue as well. And the other thing that we should look into is the partnership and the collaboration that is present in the space of EIDM, followed by the overall culture or norm of using evidence for decision-making. So when we look at this in the Ethiopian context, we cannot say that there is nothing being undertaken in there, but we are more stronger in the area of standards, because we have some knowledge translation tools here and there, even though they're not standardized. And there are also strong partnerships, especially international partnerships, but we cannot say the same about the local partnerships. So, there are different things that are being done, but because of time, I'm not going to go into detail of that. But for everyone, when we look at the EIDM ecosystem, we have to be mindful of these 6 inputs. So, okay. And one thing that I would like to bring your attention to is who are the organizations or the entities that are working on knowledge translation and evidence-informed decision-making in Ethiopia. So in the picture here, or the diagram here, the middle one that you see is evidence intermediaries. These are structures that are dedicated to knowledge translation in the Ethiopian case. So I'm not going to go through each of them, but we have different entities, especially at the federal level. But we have to bring this down to the grassroots level, to the regional level. And also there is a need for alignment integration, because most of the work that we see are really fragmented among the even the evidence intermediaries that are present in country. So talking about this, this is just, when we see things in picture, they're more, they are catchy. So as you can see here, knowledge translation is about filling in the gap between the know and the do, or it's about filling the gap between the producers and the end users. So sometimes we call them brokering, sometimes we call it intermediary, but the key thing to understand here is that knowledge translation is not a linear process. So there are different steps that we should go into, which include like scientific steps, like what I explained earlier, like synthesis, exchange, dissemination, and application. It's about packaging something in a way that is usable and making it, improving the quality and making it the best available evidence, and pushing it to exchange between the researchers and the decision makers, disseminating that as much as possible, and applying or supporting the application of the evidence that we produce. So this is something that I hope it can come up, but this is something that I would like everyone to see, which are the knowledge translation tools or the mechanisms that we're using in our directorate and also across different knowledge translation platforms. This include evidence-informed policy briefs, stakeholder dialogues that are produced for decision-making, rapid evidence syntheses, evidence summaries, systematic reviews and meta-analysis, which is one of the most popular one. We also have health technology assessment, which I think is going to be discussed about maybe tomorrow or later. And we also have scoping reviews, evidence mapping, and citizen brief or panels that are produced within the knowledge translation mechanisms, or are tools that we can ask for even for the decision makers, and that can be provided to facilitate the evidence-informed decision making. And finally, I would like to leave you with some messages. One thing is that evidence-informed decision-making and knowledge translation are like 2 sides of a coin. So we cannot talk about one and leave out the other. So whenever we think about the process of using the best available evidence to inform our decisions, it's really critical to think about how we do that and the knowledge translation process of it. And the other thing I want you to think is that in the Ethiopian context, there are, activities that have been undergoing in different activities in different organizations, especially at the federal level, but there is a need to take that to the lower level, to the regional, to the world, and to the grassroots level of our processes and our health system. And there are, leaders and especially professionals that have been working on this for the longest time, and it's really critical to tap into that potential as well. I think I've taken a little bit much time, but thank you very much for your time.
Nagajerto. I'm going to present integrated evidence generation in terms of Oromiya Health Bureau experiences. So when we say integrated evidence generation, it is an approach to collect and synthesizing resource mobilizations as well as allocations from regional governments, and also the resource utilization was highly increased. So evidence generation contributed this to the regional bureau. The other one is there is an improvement in leadership engagement and in decision making, especially when our leaders are providing decisions. They are especially exercising data-driven decision making. So integrated evidence generations are used for this one. So the challenges we have are there is a limited data quality, even though the data quality is progressing from time to time. We didn't reach the optimum level. The other one is there is a limited research capacity, as well as there is an analogy gap, especially in data analysis, as well as in conducting research. Also there is limited resources and infrastructures, like the digital infrastructures. So for the next time, we are going to strengthen our partnership, especially for on key stakeholders, optimizing use of ICT, as well as maximizing leadership engagements and this evidence, integrated evidence generations. Also, we are going to build new skills and capacities on data analytics, talent, and also we are better to coordinate and plan an integrated evidence-based evidence generation. These are what we are going to do for the next time. This is all about. Thank you.
እንዴት ዋላችሁ? እንግዲህ ከአሁን በፊት ቴክኖሎጂ ሰውን ተክቶ ነበር። አሁን ዛሬ ሰው ቴክኖሎጂ የሚተካ ከሆነ ቶሎ የሚያልፍ ከሆነ ፕሬዘንቴሽኑ ከአንድ ሰዓት ወደ 30 ደቂቃ ማሳጠር ይችላለሁ። የሚሰራ ከሆነ በዚህኛው ሊሞክር ይሰራል። ኦኬ I would like to develop on what Firmai has presented. Well, first of all, I want to stress on this statement: the lack of evidence does not necessarily mean absence of it. Why is it? Next slide, please. Okay, so well, I won't talk a lot about this one. This is the data that was generated from the daily Facebook report, official report of Ministry of Health for COVID-19. So the first part you see is COVID-19 test positivity rate and number of cases. And the second slide is, the figure is about the number of severe cases and mortalities. So I won't talk a lot because we don't have time. I would like to talk a lot about this, but just for you to make a judgment. I'm not making any judgment. I leave it to you. Was it evidence-based medicine? Sorry. So by the time the COVID outbreak was literally over in Ethiopia, we started to vaccinate. 80% of the vaccines for COVID-19 that were administered in Ethiopia were vaccinated after February 2022. By that time, we don't have that much days, and despite the highest number of daily cases and despite the highest test positivity rate, which was 40%. And put into equation this figure, by the time we started to vaccinate, 54% of the healthcare workers in Ethiopia have already been exposed to the virus, about 40% of the community. And by the time we enhanced the vaccination, 96% of the healthcare workers and the community have already been infected. 96. By the time we just enhance it, put into this, 50% of the Ethiopian population is 20 years or younger, and So the question is, the strategy we used that was practiced in the rest of the world. 2 doses for most of the vaccine, 1 dose for the Johnson & Johnson, plus booster doses. Was it evidence-based? I leave it to you. So next, by evidence-based medicine, we mean it is integrating the best available evidence with the clinical knowledge and expertise, as well as considering the individual patient preferences, as well as patient specific conditions. This is in contrary to what we think. Evidence-based medicine, we think that this is evidence that was generated through meta-analysis of clinical trials. But it has all these things because we need specific use about patients, we need clinical expertise, some of which are implicit, and most of them may be explicit experience. So what are the cycles? I will not dwell too much in this one. We have to ask a proper question. We have to solicit the evidence for it, appraise the available evidence is applied, evaluate it. But this is possible if we have the culture of scientific inquiry, and also if we publish these evidences, if we properly disseminate. Now this is very important in our context. We do lots of things we never publish, never communicate properly. And we also do not have as such, culture of scientific inquiry. So if we don't have these 2 things, if we don't do these 2 things, the cycle of evidence generation, synthesis, utilization, and then assessing the outcome and continuing the cycle will not be there. So now evidence-based medicine is like a smartphone, because we talk a lot about evidence-based practice in medicine now. There is no logic in medicine, we have to rely on evidences, but does it come with challenges? Of course it comes with a lot of challenges. Challenges we have never thought of when this idea of evidence-based medicine came. One of which is probably this was an issue that was raised in the morning. What is statistically significant doesn't necessarily mean this is clinically significant. And so we have to be very watchful of our p-values. And there is always a vested interest because, treatments and diagnostics always involve pharmaceutical companies, and most of these clinical trials are supported by this. So negative results are less likely to be published as compared to the positive results. And guidelines are always affected based on this vested interest of the pharmaceutical companies. Sometimes also there is political involvement based on the matter we are talking with. And because of this, the cycle comes, one pharmaceutical company fails and then comes with another grant, and the research goes on, guideline will be revised, and then we continue the never-ending evidence generation and utilization. Because of that, the clinical expertise and patient preference are often overlooked. That's why when we think about EBM, we always think about evidence. In fact, it's not. The thought of this linking EBM with just research is because we have overlooked because of the interest of pharmaceutical companies. And in clinical trial, what we often do is we select ideal patients. There are lots of exclusion criteria. But in real world, we don't have ideal patient. We have a patient with multiple morbidities. And in that situation, we cannot fit into multimodal approach, and there is lack of system thinking if you just rely on the evidences. Last but not least, as practitioners, we are ignorant of statistics. I'm representing as a medical doctor. Not because we don't like mathematics, not because we are poor in it, because when we treat a patient, we treat a single patient, and we don't consider the number. A rare disease is on textbook. A patient in front of you may have that rare disease. So number sometimes for medical doctors is a challenge, and you may have a problem to convince medical doctors with regards to number. So I give you one example, but the picture is not clear. So for example, you have a good evidence, recent evidence for knee surgery, medial meniscus rupture, for instance. So do you implement the same evidence for someone whose leg is livelihood as compared to a person who just uses his leg for walking. So that's why clinical expertise and patient preference is very important in the evidence basis. So to deal with this one, what we need to go is we have to move the evidences from laboratory, from journals, from conferences like this to the hands of those who use it on daily basis. Doctors, nurses, practitioners, policymakers, institutions, Ministry of Health, EPHR, for example, in Ethiopian context, as well as hospitals and professional societies. So that's what we mean knowledge translation. And I will not talk a lot about knowledge translation because it has been already addressed. It is the synthesis, exchange, application, dissemination of knowledge to improve the health of the community, the health system, and the healthcare delivery. How do we do that? Is we have to properly synthesize the evidence, interpret it. There should be a proper collaboration between those who generate the evidence and those who utilize the evidence. It should be translated into policy, context-specific, in fact, not just translating into policy, but context-specific translation to policy, and that should be disseminated. So as healthcare professionals, healthcare providers, what do we need to do? First thing is we have to know the gap. What is the knowledge gap? For me, I say that is, knowledge translation is about know and the do thing. So we have to know what is the knowledge, and we have to know also, we have to identify what is the gap in action and the interaction between the two. And the knowledge should always be contextualized. The example I brought in the beginning of my presentation should be implemented as it is from Western world, or should we contextualize the knowledge? It answers the thing that we have to answer always. And we have to know the barriers. We have to know the facilitators of this knowledge and implementation cycle. And you have to know how to intervene. You have to plan. These are all the interventions I will not talk about. And monitoring and evaluation is very important. If you don't monitor evaluation, you don't know where is a gap. You don't know also what is the impact of the action, and you have to sustain it. So what's the major challenge? I'm finishing my presentation. What's the challenge in Ethiopia? I would say we are really traditional. Something that I was taught 20, 25 years ago are still the same. Like in the hospital I practice. Now I was an undergraduate student, I'm still working in the hospital, and lots of things are the same. They never change it, even though there are certain improvements. We did not make change as much as we have to. And data quality, I think this is everybody knows. We have data, but the data we collect are not good enough. They are not useful in evidence generation. We can take COVID example, probably we'll talk later on during the answering question and answer. And the other is, most of our interventions are donor-driven and from projects, some of which are not due to, based on our interest. And we rely a lot on Western evidences for teaching, also for practice as well. And lack of trust on locally generated evidence. Sometimes we have evidences, but no evidence will not be utilized. I have a good example for TB treatment. The diagnostic approach, the first research was conducted in Ethiopia, but the Ministry of Health of Ethiopia at the time did not implement until WHO took it and endorsed it to be implemented worldwide. And there is a poor documentation of success story. And someone else should know from our failure and from our success. That should be properly documented. And monitoring evaluation, we have to have the culture of for every intervention there should be monitoring and evaluation. And high attrition rate, not just the healthcare workers, but on the leadership. There is a loss of change every time someone starts to implement, be at the ministry level, be at the institution level. Once that leadership changes, the interventions either they completely are written off, or sometimes it will not be implemented as it was planned. So the way forward is we have to move from knowledge consumers to knowledge management. if we have to make. So these are the components of knowledge management. So I will not dwell too much in this. I would like to receive questions in the end. Thank you very much.
Kamoltan. First of all, I want to thank the organizer for giving the chance to share my experiences as a facility and patient, specifically at as of Matukal Hospital. Slide. Okay, sorry for inconvenience. So mine is about data quality. So at the National Health Quality and Safety Strategy 2021-2025 specified that there is a weak compliance of evidence-based practice as a major weakness of healthcare system. So the effective implementation of evidence-based care improve the patient experience through providing quality of care, because if our care is based on the quality of care, as physician, that majority, about 80% of the care is based on the history or the good quality history we generate from our clients. So this quality history that we generate from the patient will determine the outcome of the patient. Even it helps us to reach to the correct diagnosis for the goodness of the patient. So it's also enhance the patient outcome. Even it reduces the cost and empower the clinician and leading to higher job satisfaction. So data is, most of the time, data is considered as an ingredient, the main ingredient, or it is a compulsory ingredient for the health system, because data quality matters for the outcome of the patient. So we can define data quality as fitness for use. That means quality data means the data that we use that is fit to decide, fit to manage our patient. So that's why data are fit for their intended use in operation, decision, and making decision, as well as in planning. So why quality data is important? As you know, quality data is very important for the right health care and even for the client. For the client, quality data is very important, because if we generate a good data from our clients, we can decide what medication they use, because there are information on allergies, past medical history, potential drug interaction. All these are important for our clients. So this is the data, that's the importance of data for our clients. The other thing is for hospital, institute quality improvement initiative based on performance measurement and even effective and efficient planning. It is also used for even budgeting and prompt action when needed. So to have to plan, to budget, even to provide medication for our clients, the data is very important, because the outcome of the patient or the client is not only limited by the medication we provide, the IPC practice we implement. Also, the data we use will determine the outcome of the patient, because data is very important. Even for researchers, health research finding will be used of only when the basis on good data quality. All health researches done will focus on the primary data that the data owner compiled in the previous. So if the data owner will not compile all the required data elements properly, even the researcher will mislead. So there are major dimensions of data quality. The first one is data accuracy and the validity. Accuracy of the data we generate is very important. So and also the validity of the data will matters. And then the next is consistency of the data. Are these data are consistent? The other thing is completeness. Completeness, in a sense, starting from generation, all and in most of the facilities, there are many registers, tally sheet. All these registers and the tally sheet have own data set. So if these all data sets are complete, the completeness issue will matter there. So data completeness during reporting will also matter. While reporting, the completeness of the data will also matter. Again, the timeliness issue is the major dimension of data quality, because data will go with time. So data that we need this time will not work for the afternoon or after a month. So timeliness issue is very important for decision. So this is our run chart, for example, at Tukar Hospital from January to April 2050. We have conducted a day's audit on NICU. Initially, there was a great number of days in NICU, so we have done days audit as well as daily monitoring of the dashboard with creating a dashboard. So while we are monitoring the data day to day, the days is increasing, because data quality, while we are using data quality, the dashboard, some recorded data going to be visualized. So that's what we are doing. Some other intervention, like separating the laundry machine for the NICU, and then terminal cleaning, and then IPC practice, radical IPC practice. So that's why we have managing the cases. So initially, what I want to say is data quality is our issue initially, and then finally the leaders should involved in all setting of data generating as well as management. So this is all about. Thank you.
Okay, thank you, dear our panelists. I think you have got not something, but a lot of things about the data related in the health system and others. Since you start our presentation from the national and the universal health coverage, then we pass to the evidence policy from APHI, and then Mr. Lamesa has given us about the evidence to decision-making paradigm shift and the Oromia Regional Health Bureau experience. Then we get detailed information that's useful about the health information system in the context of Ethiopian health system, and particularly the health provision, health service provision activities, evidence to policy and their processes, different processes. I think we have got a lot from the presentation of Professor Sayas, and then from Dr. Solan about the experience of Matukar Hospital. So what we do is we have one guiding patient for each of our panelists, but we need to 2 minutes to talk about the guiding questions. Then we will have a Q&A from the audience. Based on the presentation, I will have the question from their presentation based and experience. So their talk will be from their experience. So the first one is for the Mr. Wubishet about the universal health coverage and experience. So my question here is, can you mention one example where we have modified our information system at the national level to address the data needed to measure the progress of universal health coverage? From your experience, you have 2 minutes only.
Thank you, Dr. Tizta. I'll try to be as brief as possible, and I will stick with what I said earlier. We don't have a parallel system for any program. What we do have is a comprehensive and integrated system. So whatever we did to improve, the health information system of this country in terms of leadership, governance, the system itself, manpower, all contributes to accelerating progress towards universal health coverage. But if I'm asked to mention, I can give a couple of examples. One is having the index, the Universal Health Coverage Index, in our HSTP as a measurement could be one. And as I said in my presentation, there were numerous reforms of the HMIs across the years, and based on the evolving needs, the epidemiologic shift, as well as the need to address this universal health coverage, we have included some indicators like, indicator around hypertension, which we don't have back in the days, but we included it as we moved on. This is what I can say, but if I am given the chance, I want to call for action. I want to friendly and gently request the Oromia leadership at all level to take stringent and important action towards improving the data quality. I believe if Oromia pioneered this, the others will follow. So please ensure that the data that we get from especially facility and health extension workers to be of the highest quality through stringent measures. Thank you.
Okay, thank you, Mr. Wubishet. Coming to Ms. Firmai, as she is the second panelist. As you know, as you see, her presentation was on knowledge translation. So how far is knowledge translation practiced in the health system of Ethiopia? So please give us one example so that we can take and we can learn from that. Thank you.
Okay, thank you very much, Dr. Tizeta. I mean, this is a very packed question, actually, how far, to what extent. But I'll try to, mention some of my experience and also relate the knowledge translation practice in Ethiopia with that of the earlier presentation that I presented and also that was presented later of the steps that knowledge translation follows, starting from synthesis up until dissemination. So it would be an injustice for me to say that knowledge translation is not applied in Ethiopia, because since Ethiopia was represented in the EVIPNET or the evidence to policy network since 2006, there have been different activities and efforts to embed knowledge translation in the Ethiopian health context. But the question is, have we gone through all of the processes in a standardized manner and in a routine manner? And that would be yes in some context, but mostly no. Because we have some structures here and there that I have tried to mention in the presentation. We have them in the EPHI, we have them in AHRI, and there are also mentionable projects like the FNOT project and also some movements in the different regional health bureaus and public health institutes. But this process that we have taken, even with the standardized or the structures that we have been maybe starting from synthesis of evidence and packaging that, and we might reach up until the application or the dissemination of the evidence, but monitoring and evaluating that and the impact of the evidence that we have translated has been a little bit difficult, because as you might understand, seeing the impact or analyzing the impact of an evidence that you provided is really difficult and needs a system that is embedded within the health system. So I would say that we have here and there applied knowledge translation, but there's a lot to be done. And one thing that I would like to mention, which is really, would give us a hope, is that there is a new unit that is established at the Ministry of Health, which is the Policy, Strategy and Research Unit. But I would like to stress that we have to be careful of how we implement or aim to use that unit, and this is sort of a message for the unit as well. But just to provide you an example, because I was asked of an example, I would like to bring in a case that we have provided an evidence on during the COVID-19 time, which was actually a request that came from the Oromia Health Regional Health Bureau. So we were requested so the Bureau was actually planning to change the PCR COVID test to antibody test, but there was, because of different reasons, one of them being resource. So we were asked to provide the best available evidence of whether to change that into antibody test or to stick with the PCR test. So we used a knowledge translation tool, which is called the Rapid Evidence Synthesis tool. You provided the information within 30 days. And what makes this case unique is that this was what the ideal knowledge translation process should be, which started from demand. So it was demand-based. So there was an actual application of the evidence that was sought for. So actually at the end of the question, they actually consulted the information or the evidence that was provided, and the antibody test was held back. So this is one of the examples that we can show where knowledge translation should be demand-driven and also have an impact at the end of the day. So thank you very much. Yeah.
Okay. Thank you. Thank you for your sharing of the experience, particularly this experience within the Oromia Regional Health Bureau. So the next one is Mr. Mesa. So he has mentioned about the evidence to policy and decision-making experience as a regional health bureau. So we need also more about this issue from several integrated evidence generation, as you have presented, analysis and use activities. And the Oromia Health Bureau currently works on. Tell us an example, even if there were some examples in the presentation, but we want to hear more about what exemplar and paradigm shift is ongoing in the context of the Oromia Regional Health Bureau. Thank you.
Thank you, Doctor. Based on the guidance of our Bureau head, we did a very important document, what we call a system diagnosis. Based on the WHO building blocks, we did a system analysis in the context of our regions. So in that document, we put different evidences, especially what was achieved so far and what are our challenges, and to tackle those challenges, what are the prioritized interventions. So to do that, we gather different evidences like from finance bureaus as well as from different expertise and the like. So by using those these documents, we mobilize the resources to our regions by presenting the documents for different stakeholders. So this is the best experience what we have.
Okay, thank you, Mr. Lamesa. And we are happy that to hear there is a paradigm shift gradually to use evidence in the context of Oromia Regional Health Bureau. So the next one, the question goes to Professor Isaias. Evidence-based practice to knowledge translation, particularly, what are the roles of health service providers? We say it's important to have evidence and use that evidence, not only for like policy, but we have to practice it daily while we are giving care for our clients. So what are the roles of health service providers? Because there are also providers here in the system that they want to hear about those experience from you while as you are experienced in terms of these ways. Thank you.
Well, thank you very much. First of all, I would like to acknowledge what has been done over the last 2 decades since I became a practitioner. And we have moved from primarily preventive approach to now the quality of health care and tertiary care. I think that this should be commended from at least my personal perspective. Coming to the point, as I've said, the first thing is knowing the gap we have in knowledge. As for my end, I was part of the COVID task force at the Oromia Regional Health Board, at least as a scientific advisory panel. The thing we first is we try to analyze the data we had. I think you were part of it, Professor Sunil was part of it. And also first time, in the first 6 months, we had about 65,000 tested patients for COVID-19. And we were really excited because at the time there was no any data from Africa. So we thought we will be the pioneer in evidence. So we started to analyze, and I was not part of it. You were part of the analysis. The problem is, the simple thing is, for example, in one column there was age, but in one hospital put age and the other hospital was gender in it. And in certain hospitals, symptom column, everything was empty. In some hospitals, it was no. So in the end, what we found out that out of 8,900 PCR positive patients, only 97% patients had reported symptoms. This is unimaginable. It doesn't happen. So that was when we collect data as the service point, the data quality. I think Dr. Solana has already mentioned. So the first thing, our role is generate quality data. If we don't have quality data, you don't know the gap. This is we are really lacking behind. We are good at reading textbooks. We are really good in that, but we are not good in the evidence generation because we are not good in generating data. We don't document properly. We don't document the cases. If you go to the hospital, I also try to do lots of retrospective studies. You cannot conduct quality retrospective studies in Ethiopia. And so because of that, when you apply for master's thesis and if the retrospective, so the retrospective study is not a good quality. But actually you can generate, practice changing evidence from retrospective data, provided that you have a very good quality data. So first thing we have to do is generate very good quality data. How do we do it? When we treat a patient, when we register, we have to properly register it in the way it changes tomorrow. If you go to the DHIS2 data at the hospitals, that's reported to the Ministry of Health. I try to analyze it. I would say, sorry to say that, but it's not evidence. It's not the data, actually. And the second thing is knowing the gap. If we have created You know, for example, HIV is a good data, well supported from different initiatives. If you ask which system the program has a good quality data, is HIV in Ethiopia, because it was implemented through ICAP and JHU, and we had a better outcome in HIV care in Ethiopia. So know the knowledge, know the gap, and a third and the most important thing is we have to document our success story. Success story does not mean that everything we did good, but where we failed, why we failed. If we do that, others will not repeat the same mistake. So these are the three most important things what we have to do to improve the evidence-based practice in Ethiopia and in Oromia in particular. Thank you.
Okay, thank you, Professor Sayas. I think you have more information related with the data quality and particularly what we experience in the health system of the country generally about the data quality, data related. But as we promote that, using the written data is based on rather than being data collection and also a cross-sectional study. So we advocate for qualifying the data we have routinely rather than looking for other data that we can use. That's in our hand rather than looking for fund to collect the data. If we start this issue, I think we can talk more, and the time will not be enough for that. So the last, but he is an energetic young panelist we have here, is Dr. Solon. So he presented about the experience of Metu Karl Hospital. So I would like to ask him how is the interconnection between quality data generation and use to move toward health service provision, as we think that data quality generation is progressing well in Karl Metu, and other hospitals can take also experience from the activities of what has been done so far at Karl Metu Hospital. Dr. Sir.
Okay, thank you very much. In our region as well as in our hospital, there is a platform that we manage the quality of data, starting from the, actually we have implementing at the region as well as in the hospital, we are implementing currently EVC as one initiative, evidence-based care, and the other initiative is system bottleneck focused reform. These two initiatives are implemented in our hospital currently. So we do have dashboard, daily monitored dashboard in our hospital for selected indicators, because we have to prioritize things to have a quality data. So we have to prioritize some indicators, and we discuss with management, and all these selected indicators are monitored daily. So having this, we have to discuss on the data daily. Then we do have health development army or clinical forum. So on that clinical forum, all department heads and seniors engaged and discussed on the quality of data on specific selected indicators. So in addition to that, we do have PMT, performance monitoring team, that's all the selected indicators, including the using the techniques LQS and the routine data quality system. So we have checked the quality of the data, and to do this, the main important is empowering the data generator, because for me as a leader, the one who generates the data and the one who operates the abdomen, or a surgeon or gynecologist, is equally important for the quality of care, because if we have to empowering them, and then majority of the in some cases, even we physicians, I treat the patient. Why should I treat the chart? This is for majority of them considering treating the chart is just writing the patient history or writing important histories, just treating the charts. But So they should have to know, because to do this, to generate data quality, there should be a knowledge, there should be skills to capture that data, as well as from this, the main thing is attitude towards generating data quality is very important to sustaining as well as to maintaining data quality, because we have to empower the data generator that you decide the direction of the health sector, because higher officials, based on the data you generate, you guide them. So why you record what you do is very important. So if if the attitude is changed, good quality data should be addressed, even if our regional health bureau hospital director monthly the data we enter from the DHSI2 feedback is given through virtual system, so even through Telegram. So we have to tackle on that. So having good quality data is, as I previously said, is a medication for the patient, because if the good quality data is generated, based on that, the outcome of the patient will be good. And this is my assumption. Thank you.
Thank you, Dr. Salan, for your nice talk about the experience of Matt Carl. Sorry for taking long for this panel discussion, but we think that it is interesting. So we have some 10-15 minutes. So the stage is back to the audience. Now, for the presentation, we use English as a language, but now for the discussion, we will have, it depends on your choice. You can have English or Mifa or Amharic, so that it's open for discussion. As the time is running, shall I take only 5? Then we back if we have time. But please limit the question only 1 if you have most pertinent issue for discussion. This side? No? Okay, Dr. Lumis. Number 1, maybe? Then I go to the other. Okay. Okay, number 2. Number 3. 4. And number 5 at the end. We don't have time. I know Asnaka is showing me that we are almost have 0 minutes. But we will continue as audiences are more interested in it. So, number 1. Okay.
Ready. Thank you very much for presenting a very important and relevant topic again for the discussion. Yeah, one of the challenge again we had in all the system is the lack of quality evidence, obviously, for making decisions. I was part of a global guideline development group 1 month ago, actually. We're searching global evidence to change, update guidelines. Then sadly we couldn't get globally, not actually locally, evidence that is informative to change decisions. One of the challenges we put also is our healthcare program leaders, or those who are implementing in the health system actually, are they participating in raising questions and actually also using evidence for research? So the very important point I want to engage also those who are engaged in health delivery system is also they have to be part of the research question setting, not necessarily end users of the available evidence, because if there is no, there are multiple research, but they are not informing well our programs, because research is for academic completion or for the requirement. It does its purpose, but it is not actually informing adequately our programs, because it's not, the question is actually for academic most of the time. So that is where we need to also bring together program people with those who actually do research most of the time. Then setting questions and priorities is also should be the primary areas of focus, and actually just synthesizing whatever best available evidence. Whatever best available evidence, not also always informing our program decision making. This is what I also want to supplement. Thank you very much.
Thank you. Number 2. So maybe you say your name and where you are from, then directly to your question, please.
Okay, thank you very much. I'm Fork. Actually, I'm from Malaga University. My question is directly goes to Ms. Fermay, which is actually evidence translation. So here we are having panelists from different aspects, and we have seen how this is manifesting in our health system. So as a leader of this unit, especially with regard to, we have two components here. One is the evidence, the second is translation. So with regard to the evidence, how you are really doing on improving the quality we are saying here, the system. Actually, with regard to joining where the evidence is being generated, especially the universities, how we need to provide as a health system, how the universities need to act rather than just doing a fragmented way of researches. The other is especially with regard to translation, who is supposed to translate evidence? Once we have done with features that is expected to be an evidence, so who is going to translate it? At which point of the health system? Because in most of the cases, we are expecting actually based on evidence for policy. So if that is the case, we are always expecting from the ministry or some higher officials or our higher levels. So how we are engaging the health system across the health entire to really exercise the evidence translation so that we will have as a nation a good evidence to practice the translation. Thank you very much.
Okay, thank you. Before I'm going to my question, just I want to say thank you for all of our panelists giving us a due attention for this essential issue. This evidence generation, especially in system thinking and system to create a resilient and sustainable system, is a crucial issue. But something what I wanted to know or get from your best experience is just, is it the problem of our system is to generate data or evidence, or is it the accountability issue? Is there a system or any institution which is accountable for all data generated and some faults done in the system? And there are so many initiatives in our system to change this problem, and there are so many researchers who did. There is a problem of evidence generation and utilization in our system, but it is not giving any change in the system. What I want to say is we have started in this evidence generation solving mechanisms in 2006 in hospitals performance, and since the 2015 Ethiopian
national quality and safety strategy, but there is no accountability issue. From the Dr. Solan's presentation, there were some data problems before they started to collect evidence data using some evidence generation mechanism and SBFR, but no one is accounted for the problems, and just we started and we left, and we create new change ideas to solve this problem. So how we can create an accountability culture in our system, and what home tech assignment will you give for all stakeholders and especially for policymakers here to create a good accountability issue and the rewarding. There are two types of rewarding, as you know. There is a negative reward and a positive reward. So how we can create this accountability issue, and thank you for your attention.
Number 4.
Okay, thank you so much. I'm Marga. Okay, thank you. I also congratulate the presenter for the nice presentation and also insightful and detailed presentation. My question is, generally, I saw from your presentation the group who produce the data and also the information and also the end users. But I feel the place where the market can be exchanged. Where is the marketplace that can the producers and the users can also discuss and use that data? We know that individual may produce evidence and organization may produce evidence. From the pocket study, individuals also boldly say this is an evidence, and also everybody have a gut to inform policies, and also sometimes they recommend to change the policy. I worry that we may overburden the policymakers and also utilizers. This, my big gaps in this regard is, if one can produce the evidence and the marketplace is not well established, and also the quality assurance for that evidence is not set in place, that might be a challenge to change the practice that we had. This is one issue. The other issue is, most often we say that evidence-informed policy decision and practice change, and also evidence-informed medicine practice. I'm not sure who will push the finding to be take practice. If we can get an innovative evidence, who will say this is an evidence and please take it and take measures? These are the questions that I have. Thank you.
Thank you. Number 5. Okay.
Okay, thank you very much. I'm Nur Zaman Gali. First of all, I want to thank all the panelists for their presentation, and also the organizers for making such event happen. And for the sake of time, I just go to my my points. I'm very happy that we are here today in the midpoint of the implementation of the SDG, and the one of the agenda in the SDG is the universal health coverage. So we are all here for the same point and for the same goal to attain the universal health coverage. But coverage cannot be easily happen without having a quality data, and the data is used for the decision making. And things is I want to raise my question for Ms. If I call it
Firmai.
Firmai. Okay, sorry. And I want you to ask you your directorate position in working with the research institutes and the academics, because we do have plenty of researches that has been done and some are on the table and the others are on the journals. So in order to put these researches or evidences to be utilized by the policymaker, we have to have, you know, the platform that that shortens the gap or the stereotype between the decision makers and the researchers. So what your directorate has done so far, especially if there is an experience, I want you to share us your experience that you have done so far. I mean, putting some research into the policy change after the start of your project. Another one is what your relationship looks like with the universities and the academics, because it should be a proactive action. I mean, if the research has been done somewhere in the academics or in the research institute in Ethiopia, your directorate may have an access to that. So in order to browse that thing is to be changed to the policy changes. What your directorate is really doing. And another one is not only for actually Professor Isaias, but for the whole team. And one of the major problem or that makes the issue of, I mean, the data quality complex is we don't have knowledgeable healthcare providers, especially they don't give an attention for the quality data. This attention is a culture. Most of the professionals are raised to give a treatment and to give a care, but they don't give an attention for the data. So in order to change this culture, something should be done at the very beginning. We cannot change the quality of data by monthly monitoring virtually. It is very important actually to look at the numbers, but to change the problem from the very ground, we have to do something on the professionals. Most of our data quality management, they are adopted somewhere from abroad. But in looking into our context, we have to do something, especially why we should not have it in our curriculum, especially for the health professionals, to have the quality data as a subject. I don't know if I left school before 10 years back, and I don't have an update, but it's very important if you have such curriculum revised and included in our health or medical school curriculum. Thank you very much.
Thank you. Thank you. I think the first was from Dr. Lamesa. That's an opinion view, not a question. So we pass to the next, the second, third, fourth, and fifth questions. Maybe Firmai has two, and then Lamesa and Professor Sayas. So maybe we start with Firmai, and then you can take the stage to respond for the questions raised. Thank you.
Okay. Thank you very much for the questions. It shows me that, you know, it is an intriguing issue that these questions have been raised. So I'll try to address the first and the last question together because I think they're mostly aligned. So the first question is, especially with the quality of evidence, specifically to our directorate, how are we helping in the generation of quality evidence that is directly related to the questions or the gaps in the country? So first I want to state that, you know, this knowledge translation aspect and the evidence-informed decision-making process is not done in a silo. So it's like a relay, right? So you have like in the to make it in Amharic. So there's a need to be interlinked. So as a knowledge translators, what we do is try to identify the best available evidence, both local evidence, if it is present, and triangulate that with the global evidence that is present. So when I say evidence, it could go from expert opinion up until, as I said earlier, to the highest quality evidence. So what we do is collate that and try to synthesize it in a way that is usable by the decision makers. But when we do this, one of the things that we try to do is identify the questions and also look at the evidence. And what we have seen throughout our experiences, mostly, especially in our local context, most of our studies are present on the, even the ones that we have done are present up until, scientifically speaking, the cross-sectional studies, and sometimes, might go to the case control studies. But in a specific context of Ethiopia, it is really rare to find studies that are done in randomized control trials or even systematic reviews of randomized control trials. So one thing that we can do is, identify the evidence that we have and indicate the ones that we don't have. But I just want to mention here that it is something that should be done interlinkagely. So we cannot, be involved in the generation and also in the translation and application. But one thing as a translator that we can do is indicate into the caps that we have tried to do with the study that I have shown you earlier in the slides, which is the assessment of the ecosystem of evidence-informed decision-making in Ethiopia. That also shows as a section of the findings that there is, mostly a low-quality evidence or generation in the Ethiopian context, but that does not mean that the evidence that is presented in the country is invaluable. And the second question, I think, is about who is supposed to translate. So this is also a very packed question, but I'll try to divide it into, so who should lead translation and who should be involved in translation. So when we talk about the concept of knowledge translation, even with the experience that we've seen from different countries, the leaders should be the translators or the intermediaries or the brokering like ourselves and some of the intermediaries that I've mentioned earlier. But to do translation, it should be, the overarching or the cross-cutting issue is engagement or involvement. So in the translation process, even though the translators are leading it, both the producers of the evidence and the end users should be included. When we say end users, it's not only about the decision makers at the highest level, it could be the citizens, right? That's why we have the citizen briefs, the citizen panels that are produced. So when we talk about this, and again, I want to come back to one of the terms that was used, which is proactive. And of course, it is one of the aims of the directorate to have a proactive producer or decision maker or a system that raises question and brings out question and prioritizes question where it's demanded from us to be responded to. But this needs, decentralization of the different knowledge translation entities that we have at the federal level and getting that to the lower level. That is also started in some of the presentations that we have seen earlier. So again, I would say that we should be leading it, the translator, but at the same time, it needs the involvement of both the ends of the producers and the end users. And finally, I want to say that how do you work with the academics was also one of the questions, and one of the things I want to mention is that there is a coalition that is being established now that is that holds knowledge translators across the country. So I think this is one thing that could be a groundbreaking initiation in the future, but at the same time I want to stress that there is a need still for capacity building, both human capacity building and also institutional and organizational capacity building that is really, a need for us to move further into, each academic organization. But as an example, we have formalized relation with universities like Jama University, where we have a memorandum of understanding to be involved together in the endeavor of knowledge translation. So I hope I have touched upon some of the questions. If you have further, we can talk about it in person as well. Thank you.
Thank you, but we are running out of time, so please be brief when you respond to the questions.
Thank you very much for the comments and the questions. Actually, when we talk about evidence generation, firstly, we have to talk, I think, about data quality. So when we say data quality, it starts from the lower levels, especially for service providers. So the service providers has to give an attention for data quality. So if the data quality is very good, or it is reached it is optimum level, generating the evidence is uneasy. So I think everybody has to take an attention for data quality. The other thing is the organizational factor is contributed for this. So to generate an evidence, the organizations has to have the plan to generate from where he is going to generate an evidence for what is generating an evidence. So he has to have, the organization have to have the plan for integrating an evidence. So I think as a system, we have a good system, especially in collecting data as a sector, especially as a system. We have an HMI system. I think we have no problem on that, but we have a problem in its implementations. So accountability starts from the implementation, not from the system. So every institutions, every body working on the data, collecting the data, has to take an attention before an accountability. So when we do that, I think we can have an excellent data. So I think this is a factor. The other thing is, I think behavioral is another factor, especially in terms of capacity. As already mentioned, our health professionals at lower levels, they have lack of, especially in translating as well as in generating an evidence, especially in capacity areas. So we have to work on capacitating their skills on data analysis and the use. So when we doing this, I think they can generate an evidences. If the evidence was generated, I think use is very practical. So I think better to work on behavioral factors is also, I think, as a system is very important.
Okay, thank you. Maybe related with marketplace and others, Professor Sayas.
በአማርኛ ይቻላል? አዎ በአማርኛ ላውራ። አንድ ድሮ አንደርጋጁዌት ያስተማረኝ አስተማሪ 2 ዓመት ሳይማር ያስተማረኝን ህዝብ አገለግላለሁ፣ የተቀረውን ደግሞ መጽሐፍ ጽፎ ያስተማረኝን ህብረተሰብ አገለግላለሁ ሲል ነበረ። እንዳለውም ሳይቆይ አሜሪካ ሄዷል፣ እዛ ነው ያለው። ለምንድን ይሄንን ያነሳው? ቅድም የተነሳው ጥያቄ እንዴት ነው ካልቸር ኦፍ ዳታ ጀነሬሽን፣ ዳታ ኳሊቲ፣ ሎካል ኤቪደንስ ሪሊያንስ እንዴት እናመጣለን በሚለው እኔ አንተም ያነሳው ጥያቄ እዚህ የተነሳው ጥያቄ ሁሉንም እንመልሳለን ብያለሁ። እዚህ ያለው ሰው ዛሬ ይመልሳል ብዬ አላስብም። እኔ በግሌ ግን እስከ መቼ ነው ኢትዮጵያ ብቻ አይደለም አፍሪካ ሁሉ ጊዜ አሁን በእንግሊዝኛ ነው ሁሉ ነገር። ኖርዌይ 5 ሚሊዮን ህዝብ ነው ያለው፣ እኛ 124 እጥፍ እንበልጣቸዋለን። ግን እኛ በእንግሊዝኛ ሁሉንም ነገር የምንሰራው እንደ ሱሪ ያጠረን is this sustainable? አሁን ማድረግ አይቻልም፣ ግን ወደዛ ሙቭ ማድረግ የለብንም ወይ? ሪሰርቾቻችን ስታዩ አንዳንዶቹ በአማርኛ ቅላጼ በእንግሊዝኛ ፓብሊሽ የሚደረጉ ሪሰርቾች ናቸው ያሉትና ፒር ሪቪው ስታደርጉ ይሄ ሰውዬ እንደ ከየት መጣ አንዳንድ እንደው አካባቢው ራሱ መገመት አያስቸግርም እና ሲላኩ ኢትዮጵያ ውስጥ ያሉ ጆርናሎች ያን ያክል ብቁ አይደሉም እና ወደ ሲላኩ ዳውም አሁን ብዙዎቻችሁ ደርሷቸዋል መሰለኝ ወደ ኢትዮጵያ ነው የሚላከው እና ኢትዮጵያን ፐብሊሽ የሚላኩ አርቲክሎች አብዛኛው ወደ እኔ ከሚላኩት ምናልባት 90% ኢትዮጵያዊ እየሰራ ነው ምናልባት ይገባዋል ተብሎ መሰለኝ ብዙ ሰውም እንደዛ መሰለኝ ስለዚህ እኔ ጥያቄ መቼ ነው ወደ ካልቸራሊ ሴንሲቲቭ እንድንሆን እንዲገባን አድርገን እንድንጽፍና ሳይንሱን እንድንረዳ ምናምን ለምሳሌ ፔሸንት ስናክ በእንግሊዝኛ ነው የምንጽፈው አሁን ወደፊት ለምንድን ነው በሎካል ለምሳሌ ኦሮሚያ ውስጥ ለምን በአፋን ኦሮሞ ማንጽፈው ወደዛ ብንሄድ ጥሩ አይደለም ወይ ወደፊት ማለት ነው እየመለስኩ አይደለም እየጠየቅኩም አይደለም ግን ለሁላችንም ወደፊት እንደዛ ካልሄድን ያለውን ዓለም የደረሰበትን መድረስ አንችልም ፎር ኦል አፍሪካ ለእንትን ብቻ አይደለም think ይሄኛው እንደዛ ነው ሁለተኛው የመጀመሪያ ላይ ያነሳውትን ዶክተር ለሜሳም ያልከው ለኤቪደንስ የለምና ኤቪደንስ ጄኔሬተር አልተደረገም እኩል አይደለም ለምሳሌ ቅርብ ጊዜ የሆነ ስኮፒንግ ሪቪው እየሰራን ነበር ኢትዮጵያ ውስጥ ኮቪድ ቫክሲን አክሴፕታንስ እና ሄዚታንስ ምን ይመስላል ኢትዮጵያና ታንዛኒያ ኮምፔር ለማድረግ ጀመርና ኤክስትራክት ማድረግ ጀመርን ዳታውን እና መጨረሻ ላይ ኢንክሉድ ካደረግናቸው 76 አርቲክሎች 74ቱ ከኢትዮጵያ ነው ታምናላችሁ ኮቪድ ቫክሲን አክሴፕታንስ እና ሄዚታንስ 74 አርቲክል አለ ኢንክሉድ ያደረግነው እና ምንድነው አናላይዝ እናደርገው ቫክሲኑ ከመጣ ጊዜ ጀምሮ ሲግኒፊካንትሊ ቫክሲን አክሴፕታንስ እየወረደ ነው ሄዚታንስ በጣም እየጨመረ ነው ተጠቅመናል ይሄንን ኤቪደንስ ታንዛኒያ 2 አርቲክል ነው ያለው አልሰሩትም ምክንያቱም አግፍል ስለነበረ ሊሆን ይችላል ግን እኛ ጀነሬት አድርገናል ተጠቅመናል አልተጠቀምንም ቤስት አቬሌብል ኤቪደንስ ማለት ይሄ እኮ ተወሰነ ነገር ኳሊቲ ኤቪደንስ ነው አይደል ላይሆን ይችላል ግን ተጠቅመናል ወይ ጀነሬት ተደረገው ለምንድነው ኳሊቲ ኤቪደንስ ጀነሬት አላደረግነው እንግዲህ የሞንጅ ለክሶ መልሶ እንዳትሉኝ አምና ማንስቻለሁ ኮምፒቲቲቭ ሪሰርች ግራንት ኢትዮጵያ ውስጥ የለም ለምሳሌ ፒኤችዲ ተማሪ 60,000 ተሰጥቶት የፒኤችዲ ዲሰርቴሽን ይሰራል እንዴ በአሁኑ ጊዜ 60,000 ብር አይደለም $60,000 እኮ ኳሊቲ ያለው ሪሰርች ሊሰራ ይችላል ላቦራቶሪ እንዲሰራ ደግሞ ይጠየቃል ኮምፒቲቲቭ ሪሰርች ግራንት ኢትዮጵያ ውስጥ እስካልመጣ ድረስ ዶነር ድሪቨን እኛ ግራንት እያመጣን ነው ያው እንደ ዳውሃት ይሄን ያክል ግራንት አምጥተናል በእናወራለን እንደ ሳክሰስ ግን አንዳንድ ጊዜ እንደ ፌለር ነው ማለት ምክንያቱም ኮሉ የሚወጣው ለኢትዮጵያ ኮንቴክስት አይደለም አሁን እኛ በሰፉልን መሰረት ኮቪድ ላይ ኢትዮጵያ እንደዚህ አይነት ሪሰርቾች አሉ አንዳንዶቹ እንደውም የሚጠየቁ ለምሳሌ አሁን ያለ የሚሳተፍበት ኢሮፒያን ዩኒየን ፋንድ የሚያደርገው ስለ ኢሚዩን ሪስፖንስ አንዳንዶቹ ለኢትዮጵያ ኮንቴክስት ምንም የማይጠቅሙ ነው ዳታውን ኮሌክት እያደረገ ነው ምክንያቱም እስካሁን ጀነሬት የተደረገውንም አልተጠቀምነው ሶ እኔም እንትኑ አንደኛ ሎካል ግራንት አይ ቲንክ መኖር አለበት ብዬ አስባለሁ በደንብ ይሄ ኤምፋሳይዝ መደረግ በስትሮንግሊ ኤምፋሳይዝ መደረግ አለበት ከዛ ውጪ እኔ ካሪኩለም ብቻ መቀየሩ አይደለም ያንን የሚቀየሩ ሌላው ኖሌጅ ኢንዲጂነስ ኖሌጅ ቦታ ተሰጥቶታል ወይ ሌላ ነው መጠየቅ የሚፈልገው ለምሳሌ ቅርብ ጊዜ አርጁን ሜክሲኮና የሚባል አንድ ኢትዮጵያ ውስጥ የሚበቅልና የሆኑ ሰዎች ይዘው መጡና አንቴና ፋውንዴሽን የሚባል ሪሰርች መስራት እንፈልጋለን አሉ ኢትዮጵያ ውስጥ አለ ወይ ብሎ ጠየቁን አየለም ብለን ተከራከርን የሆነ አሳዩን ፒክቸሩን አሳዩን እደን ስንጠይቅ ጅማ ሰርቪስ ሲሰራ ለወባ ተብሎ ይጠቀምባቸዋል ሰዎች ይጠቀሙባቸዋል እኛ ግን አናውቀውም ኤቪደንስ showed it has benefit mechanism of action እስካሁን አልታወቀም ኮሚኒቲ ይጠቀማለን እኛ አናውቀውም ሶ ኢንዲጂነስ ኖሌጅ ቦታ ሊኖረው ይገባል ካልቸራሊ ሴንሲቲቭ እና ሪስፖንሲቭ የሆኑ ኤቪደንስ ጀነሬት እንድናደርግ ሎካል በሆነ አፕሮች ብንሰራ ወደፊት ጥሩ ይሆናል ብዬ አስባለሁ አይ ቲንክ መልስ ነው ብዬ አላስብም ጥያቄ ነው እኔ አመሰግናለሁ
እሺ አመሰግናለሁ እኔም ወደ አማርኛ ቀይራለሁ አስተያየቱን እንቀበላለን ስለዚህ ከፓናሊስቶቻችን ምናልባት መናገር የሚፈልጉት አንድ ነገር ካለ እድል ውስጥ ተናገራችሁ ሐሳብ ካለ አንድ ነገር ብቻ ሰዓት ስለሌለን አንዳንድ
just a word የለሜሳን ብቻ ለማጠናከር in terms of data quality, we've done, implementation research, overall prism ተጠቅመን የሰራነው assessment አለ. So improving data quality በአንድ ነገር ብቻ እንደማይመጣ መገንዘብና በተለይ ለሩቲን ሲስተሙ ነው ይሄን እያወራለሁት comprehensive የሆነ look and comprehensive የሆነ action. So there is no one single remedy for the poor quality that we have. የሁሉም ሰው ማድረግ behavioral capacity ሲስተማችንን ሪቪዚት ማድረግ እና መሰል ሌሎች በጣም ብዙ የዳታ ኳሊቲ አሹራንስን ለማምጣት ያስቀመጥናቸው ስትራቴጂዎች አሉና ሁሉንም ኮምፕሬሄንሲቭሊ መተግበር። ሌላው ሊደሮች በተለይ ሪዋርድ ሲያደርጉ ዳታ ኳሊቲ አሹራንስን ያላማከለ ፐርፎርማንስን ብቻ የተመለከተ ሪዋርድ ለዚህ ዳርጎናልና ከዚህ በፊት ወረዳዎች ኢንዲቪጁዋልስ ባደረጉት ታላቅ ፐርፎርማንስ ሸልመናል። ያ በጣም ብዙ ባክፋየር አድርጎብናል። በጣም መጠንቀቅና እንደው ያልሰራውን ዜሮ ብሎ ሪፖርት ያደረገን ኢንዲቪጁዋልና ኢንቲቲ መርጦ መሸለም ምናልባት ወደፊት የምናደርገውን ጉዞ ያሻሽላል።
እሺ ዶክተር ሰላም ብለው ነገር
እኔ አንድ ነገር ብቻ ነው የምለው ያው የተባለው ሁሉ ዳታ ኳሊቲ ስንል ያው እህል እንደምናየው እህል ሆኖ ሲመጣ ጥሩ ኳሊቲ ያለው የለው ምንለው ያው መሬቱ ላይ ነው መሬቱ ማዳበሪያ ያለው ምናምን ላይ እንደሚወሰነው ሁሉ ሆስፒታልን ጨምሮ ፋሲሊቲዎች ዳታን ጀነሬት የሚያደርጉ ናቸው። እዚህም በሚኒስትሪ ደረጃም በሪጅን ደረጃም ዳይሬክሽን የሚሰጥበት ፖሊሲ ሜክ የሚደረግበት ከታች የመጣ ዳታ ላይ ነውና ሆስፒታል ሄልዝ ሴንተር ሄልዝ ፖስት ላይ አቴንሽን ሰጥተን እዚህ ውስጥ ብዙ ፓርትነሮችም ተቀደም ሲሰማ ነበር አንዳንድ ፕሮግራሞችም ሰፖርት ይደረጋል። እንደዚሁ ዳታ ጀነሬሽን ላይ ዳታ ኳሊቲ ላይ በደንብ አጽንኦት ተሰጥቶ ቢሰራ የተሻለ ምክንያቱም እኛም እንደ ፋሲሊቲ እንደ ሊደር ሁም ዊ ጀነሬት ኳሊቲ ዳታ የሚለውን በጣም ማሰብ አለብን። ለማን ነው ለኦሮሚያ ጤና ቢሮ ነው ዳታ የምንልከው? ለማን ነው ጀነሬት የምንሆነው? ለሊደሩ ነው ዘላለ ለሲኦ ለማስደሰት ነው ወይ ደግሞ ሪጅን ላይ ያለውን ሰው ለማስደሰት ነው ወይ ደግሞ ስለሚፈለግ ብቻ ነው? ዳታውን ጀነሬት የምናደርገው ለፔሸንት መሆኑ ለምንሰራው ስራ ውጤታማነት መሆኑ አቴንሽን ቢሰጠውና አትሊስት ብዙን ጊዜ ዳታ እንደዚህ ሆነ ብቻ ከማለት ብዙን ጊዜ ይወራል ስለ ዳታ ኳሊቲና to the grassroots level attention ሰጥተን ብንሰራበት ዴይሊ ሞኒተር ማድረግ ያስፈልጋል። ያለን የሰው ኃይል ራሱ ዳታ ጀነሬት ማድረግ ላይ ብዙ ታይቶ እንትን ቢባል ጥሩ ነው የሚል ሐሳብ አለኝ። አመሰግናለሁ።
እሺ አመሰግናለሁ ፓናሊስቶቻችን ላቀረቡት ፕሬዘንቴሽን ለሁሉም ነገር እባካችሁ አመስግኑልኝ። ስለዚህ ታግሰው ለቆዩት አባገዳ አደስንቄ እንዲሁም ሃየር ኦፊሻልስ በጣም ልናመሰግን እወዳለሁ። ስለዚህ በዚሁ እንጨርሳለን። መልእክት ከሌለም በስተቀር መልእክት ይኖራል? እሺ
ሁሉንም ፓናሊስቶች በደንብ እናመሰግናለን። አንዴ እስቲ ሞራል ስጡልን። በደንብ ሞራል ስጡልን። ወደ ቦታቸው ሌላው ወደ ቦታቸው ይመለሱልን ከክብር ጋር ኑ ሲመጣ ስሪት በደንብ አጨብጭቡልን። በደንብ ተቀበሉልን። እንዲህ ያልን አሁን ቆይተናል። አሁን ደግሞ ትንሽ ራብ እያለን ስለሆነ ሁላችንንም በባህላችን መሰረት መጀመሪያ አባገዳዎችን በክብር እንሸኛቸዋለን ወደ ምሳ ቦታ። በመቀጠል የክብር እንግዶቻችንን ከዛ በኋላ ሁላችንም ምሳ የምንበላው